Thanks. And I enjoyed that talk. It's really useful to think about how we treat these patients. I happen to be involved with a CAR T study at Penn. That's not my work. It's Amy Payne's work there. And it's too early to tell, but certainly it's exciting just to have, so many things in the pipeline for these diseases. And that's a nice segue into talking about HS, where we do have many drugs in the pipeline. Neutrophilic diseases, somewhat fewer drugs in the pipeline, but these are broad topics, 30 minutes for both of them combined, so a lot of ground to cover. I will do my best. And I'm going to start off with a case. This is a 52-year-old gentleman who presented to an outside hospital with a, quote, bug bite on the right hand. At least that's what he thought it was. This is his cell phone picture of what that lesion initially looked like. And he was treated with broad-spectrum antibiotics for possible cellulitis. The site became necrotic, so he went for surgical debridement. The wound broke down again. He got more debridement, and then ultimately some amputations of the site, blood and tissue cultures repeatedly negative, and ultimately transferred to us with a request for hyperbaric oxygen therapy because, quote, the wound wasn't healing. So this is what his hand looked like at the time that he came to us. And I'm going to highlight throughout this talk pearls for each of these neutrophilic dermatoses and also HS. So pearl number one, when something doesn't respond to particular treatment as you expect it to, that's an opportunity, right, to hit pause, take a step back, reassess. Do we have the right diagnosis? Are we doing the right thing for this patient? And that did not happen early enough for this gentleman. So that's his right hand. Here's his left arm. He's got quite an impressive ulcer on this side as well. And at the time of transfer, he actually comes straight to our ICU. He's tachycardic, he's hypotensive, tachypnic, hypoxic, altered, white count of 40, diffuse pulmonary infiltrates. The guy looks septic. And so that's really the operative question. Is he infected or not? And certainly, I'm not going to tell anybody to stop antibiotics for a guy that looks this sick. But there are some clues here that are suggestive of a diagnosis of pyoderma gangrenosum, right? First, this clinical appearance of this violaceous gunmetal gray border, this undermined ulcer. And we see that here in a different patient, that violaceous gunmetal gray border here. And then, as patients often describe the initial lesion, this violaceous pustule. And there's also this history of pathergy. Perhaps present in a third of patients, but highly characteristic when there for pyoderma gangrenosum, this concept of injury to the skin creating or worsening a lesion. And unfortunately, as he got these debridements, that was adding fuel to the fire. So what workup is appropriate? You've often heard it said that PG is a diagnosis of exclusion, and that's true, I suppose. I think for those of us in dermatology who have seen this, certainly a lesion like this with this violaceous border and the story would be highly suggestive. But the differential for ulcers is broad, and PG is somewhere near the bottom of that list, right? So many times it's not PG. And so we want to make sure that we're doing our due diligence, right? Biopsy and a tissue culture of this violaceous border is helpful to rule out some of these other possibilities. And so this was a study that used a Delphi consensus exercise to come up with diagnostic criteria, and then they tried to validate them against published cases in the literature, and here are their criteria. So a major criterion being biopsy showing neutrophilic infiltrate, and then minor criteria, a lot of clinical things, having particular features of ulceration, rapidly occurring, peripheral erythema, undermining border, cribriform scarring, and so forth, but also exclusion of infection, pathergy, presence of an underlying condition. And it had a pretty good sensitivity and specificity of diagnosing these patients. Because the clinical appearance is so important, I've got a few photos in here just to show some of the things that PG can do. Here we've got a violaceous inflammatory lesion that is in the process of vesiculating. Here we have violaceous gunmetal gray erythema. Here in a patient with darker skin, perhaps a little bit harder to pick up on the erythema, but again, that kind of gunmetal gray, couldn't describe that any better here. Pathergy, patient having breast surgery, developing pyoderma gangrenosum at the site. And then this kind of cheesecloth or buckshot appearance, and these are patients that are sort of in the midst of starting steroids, and so perhaps inflammation calming down and sort of left behind this kind of buckshot appearance. And then finally, this is so-called vegetative pyoderma gangrenosum. I think this is really tough because, of course, we want to rule out infection. It looks so odd, but we want to also be thinking about pyoderma gangrenosum in lesions like this if they're not behaving the way we want them to. And the same patient here, this is an example of what we call cribriform scarring, that kind of tissue paper type scarring that we see. All right, so what percentage of the time is PG associated with an underlying medical disorder? And the answer here is half to 2/3. I think the textbooks will say half. A cohort that we put together, it was up to 2/3. We might be a little bit biased as a referral center. But this includes things like inflammatory bowel disease, inflammatory arthritis, but also cancer, both solid and liquid malignancies, and also hematologic disorders like monoclonal gammopathy. IBD, more common in younger patients, and inflammatory arthritis and hematologic disorders more common in our older patients with PG. So case in point, this is a woman with myelodysplastic syndrome. We were asked to see on the inpatient service. She had had a port placed to receive chemotherapy and then had wound breakdown at the site of the port placement. You can see that violaceous gunmetal gray. And the question here is, what's going on? Why is this happening now? Well, there's trauma, of course. Myelodysplastic syndrome is associated with pyoderma gangrenosum, but on repeat bone marrow biopsy, she actually now meets criteria for AML, and so this is a case of pyoderma gangrenosum heralding transformation of MDS into AML, and there have been cases of this published in the literature. And so pearl number 2, we always want to ask the why here, why now question. This is like the cool and exciting part of being a dermatology consultant, is being able to tell something about the patient's underlying health status based on what we see on their skin. All right, so pearl number 3 then, to kind of bring it together, our workup of PG is going to be to do our due diligence, get a biopsy, get a tissue culture, help rule out other diagnoses, screen for underlying medical conditions with a good review of systems, good exam, and a targeted workup, things like GI, rheumatoid factor, SPEP, basic labs, even ANCA, because patients with granulomatosis with polyangiitis can present with ulcers as well. All right, so with all that being said, there are 2 critical management issues here, right? This patient looks septic, he's super sick, and he's lost his right hand, unfortunately, and now he's got a limb-threatening left arm ulcer. And so do we wait for the biopsy and the tissue culture to come back before treating? Could this patient have systemic infection? Sure. Like I said, I'm not stopping antibiotics. But could this presentation that he has actually be from the condition itself, the pyoderma gangrenosum? Well, it turns out that PG can involve other organs, and published cases in the literature of this really have to do with sterile neutrophilic infiltrates of, say, the lungs, for instance, which are really hard to prove and show, and so these cases tend to be rare. But more common than that, I would say, is this kind of overwhelming inflammatory response, where the patient has kind of this capillary leak phenomenon, where there's hypotensive, they get pulmonary infiltrates, and really everything that this patient is experiencing, his leukocytosis, confusion, hypoxia, all of those things can be explained by PG. And so pearl number 4 is that PG itself can cause a patient to be systemically ill. And when we think about that broader spectrum of neutrophilic dermatoses, here Sweet syndrome, it's right there in the name, otherwise known as acute febrile neutrophilic dermatosis. These patients have fever, they have systemic features of their disease. And so it's easier for us to wrap our heads around this concept. This is a patient, whenever his cutaneous sweets was active, he developed painful joint swelling. When those joints were tapped, it showed a sterile neutrophilic infiltrate. Patients can have pulmonary manifestations, as I mentioned. They can even have respiratory failure. This was a patient like that who had been intubated, and we had biopsied this lesion, which, to rule out infection, ended up being Sweet syndrome. And you can see this is what pathergy is. Day by day, that lesion just blows up. There's my little stitch kind of buried in the middle there. And this patient actually developed pathergy of her airway from the ET tube and ended up having to get a tracheostomy. So, by the way, most of these Sweets cases are in patients with hematologic malignancy, where it's really just turbocharged. And these patients can develop a sepsis or shock type picture, such as this gentleman who had recurring trips to the ICU with, quote, pressor refractory sepsis, culture negative sepsis, and when he finally would get steroids as like a last ditch effort, he would miraculously improve because they were really treating his Sweets. And so these patients are complex, right? And we, as the dermatology consultant who understand this disease best, have to take time to explain the pathophysiology, explain the need for systemic steroids. So in addition to causing systemic illness, this is also quite obviously a limb-threatening process, and I've got this arrow here to show you where the biopsy was done. And I said we like to biopsy the border, right? Well, this picture was taken the day after the biopsy was performed, and the border isn't the border anymore, right? This is expanding like literally before our eyes. And so this has major functional implications. So there is clearly a cost to inaction. What about the cost of action, right? What is the team concerned about? Well, they're worried that if we treat this patient who might have an infection with high-dose steroids, are we going to make it worse? And I would say that in conversation with infectious diseases, whenever this comes up, they're comfortable usually giving steroids to a patient who otherwise seems to need steroids, as long as we are covering for infection. And as I mentioned, steroids are given as part of our algorithm for pressor-refractory sepsis. And we're lucky because PG and Sweet syndrome, they respond so rapidly to high-dose corticosteroids that we'll know pretty quickly whether we're right or wrong. So pearl number 5, ruling out other diagnoses is important, but quick action may be critical. And we, again, as the dermatology consultant, have to have the courage to think through those possibilities, risks, and benefits, and take a stand. Usually this involves having conversations with our colleagues. So what therapies might we choose? Well, we have 3 first-line therapies. Corticosteroids, high dose, usually 1 to 1.5 milligrams per kilogram per day of prednisone equivalent, and this has been shown to be effective in a randomized trial. It's our easiest to get, fastest acting, most reliable therapy to choose in this setting. Infliximab, this is, in my view, kind of the steroid-sparing agent of choice, shown to be efficacious in a randomized controlled trial from the GI literature. But obviously can't get it right away. And then cyclosporin, this is a sort of co-first-line agent, also shown to be effective in that same randomized trial against steroids, but has some important long-term toxicities, as do steroids, and in my own experience, really best reserved as an option for refractory disease. All right, so here's our patient. 1 day after getting steroids, you can see that violaceous gunmetal gray border beginning to melt away, and he also improves clinically to the extent that he's able to leave the ICU. So pearl number 6, use that inflammatory violaceous border to gauge response to therapy and guide steroid taper. This is a woman who developed violaceous gunmetal gray inflammatory border and wound breakdown following a hernia repair and paniculectomy. And we made the diagnosis of pyoderma gangrenosum. We started her on steroids, and here she is after a few days of steroids. And I can walk into that room with a straight face and say, this looks great. And of course, then I'll have to backtrack and say, okay, it's still a huge wound. We've got a lot of work to do. But from a pyoderma gangrenosum perspective, we are right where we want to be. That inflammatory border is gone. We have it controlled, and we are on the road to recovery. So acutely, the presence or absence of that violaceous inflammatory border tells us if we've got the correct diagnosis, correct management. And later, it tells us when we can taper immunosuppression. So if a patient like this is admitted to the hospital for worsening ulcer, we need to answer the question, is this active PG or not? This patient had dose escalation of steroids because this ulcer, quote, wasn't healing. They were worried about PG. And it may have been PG at one time, but when you look closely, you do not see a violaceous inflammatory border. Or consider this ulcer. It's large and ugly, but it's not active PG. There's no inflammatory border. Compared to how this patient initially presented, there you have it, violaceous inflammatory border there. And so pearl number 7, at a certain point, PG ceases to be PG and becomes instead a wound healing issue, right? Especially on the lower leg. These all eventuate into venous stasis ulcers, and high-dose immunosuppression is not an appropriate treatment for stasis ulcer. So we have to make our decisions based on whether there is active inflammation or not how big or impressive the ulcer happens to be, and there's no substitute, obviously, for good wound care. So in addition to avoiding unnecessary steroids, we also should be prepared to manage complications, right? Most bone density is going to be lost in the first several weeks of steroids. We want to think about having patients on calcium and vitamin D from the get-go, thinking about DEXA scan, counseling about blood sugar elevation, PCP prophylaxis perhaps, and other things as well. And we want to initiate steroid-sparing agents earlier rather than later. Things like dapsone, topical steroids, infliximab I mentioned, as well as others that have a role. So pearl number 8, think proactively about complications of therapy now, not 3 months from now. And this is a JAD-CME article we published a few years back about prevention and management of glucocorticoid-induced side effects. And I figure if we're willing to prescribe these drugs, we should also know a little bit about how to avoid and manage potential complications. All right, so back to our patient. Day by day, he improves on steroids. He's able to heal this wound and is able to go back to the OR to cover his amputated site. And so the final pearl, even the largest of ulcers can heal, and successful treatment of PG wounds like this can be extremely rewarding. And whereas this may not be an image that a Mohs surgeon or a plastic surgeon would put in their sort of portfolio of awesome cosmetic outcomes, for a medical dermatology medical dermatologist, this isn't half bad. These patients, again, very rewarding when they get finally healed up. So to summarize our management pearls for this section of the talk, when something doesn't respond to a particular treatment as you expect it to, take a step back, reevaluate, reassess, do you have the right diagnosis? I think that's important for all of medicine, not just derm. We always want to ask the why here, why now question. What we see in the skin may indicate an underlying disorder. PG workup should include biopsy, tissue culture, as well as targeted workup looking for systemic disease as a trigger. PG itself can cause a patient to be systemically ill. Ruling out other diagnoses is important, but quick action can be critical. We want to use that inflammatory violations border to gauge response to therapy and guide our taper. At a certain point, remember, it becomes a wound healing issue, not necessarily active PG, and we want to act accordingly. Think proactively about complications of therapy, particularly steroids. And finally, even the largest of ulcers can heal. There's hope for these patients. All right, so let's segue into talking about HS, and I'll tell you about this gentleman, 60 years old, history of severe acne as a teenager, presents now with rapidly worsening erosive lesions in the axillae, groin, and perineum, initiates ultimately after some side ventures into antibiotics, infliximab, and initially responds. He is getting better, but then that response seems to wane, and he's now no longer really getting any efficacy, it seems, out of infliximab. So what do we do when a biologic therapy of choice, such as adalimumab or infliximab, is not working? What troubleshooting should we do, and what adjustments can we make to improve response to therapy? Well, first, who are we talking about exactly? Which patients are these that are candidates for biologics? Well, these are folks with moderate or severe HS, Hurley 2 or 3, who have either failed antibiotics, such as doxycycline, or other therapies like spironolactone that we use frequently, or perhaps they have disease that's severe enough to justify biologics from the start, assuming the insurance will pay for it. So these are patients who look like this, Hurley stage 2, with single or multiple recurring abscesses and sinus tracts, about 28% of our total number of patients. Or patients with Hurley stage 3, where now an entire anatomic unit is taken up by these interconnected tracts and abscesses, about 4% of patients. But of course, our clinics are enriched with patients like this because we get the referrals and because they're hard to make better, so they keep coming back. We see a lot of these patients. All right, so which therapies are supported by available data for use in these patients? Well, of course, this conversation has to start with adalimumab, and you'll all be familiar with these studies, the pioneer studies that led to FDA approval of this drug for HS. And so this dosing weekly of adalimumab following loading, and I'll just highlight that the response to therapy, defined by high score, that's a high score 50, 50% decrease in inflammatory nodules and abscesses at week 12. About half of patients treated with adalimumab meet that metric, 50% improvement, okay, versus a quarter of placebo patients. And so we can conclude from this that, okay, weekly dosing of adalimumab is effective for the disease, and as I mentioned, it was approved for that reason. I would refer to adalimumab as our gold standard and gateway biologic therapy for HS. Why gold standard? Well, because everything else is compared now against that metric, right? And why gateway? Because if you're going to give a biologic for a patient with HS, this is what the insurance will let you use first. So there are a few additional things we can glean from continuation phase data of these trials. Among responders, staying on the drug is safe and effective. Okay, that makes sense. But patients who respond at 12 weeks can have flares still. They can lose efficacy over time. And so this means that it's effective, but it's not perfect, right? And we see that in clinical use. Not everybody responds. Many who do respond can still have waxing and waning disease. How about patients who have a partial response? So those who had some improvement, but not quite 50% improvement at week 12. Many of those who stayed on the drug ultimately reached 50% improvement at week 36. But if you haven't had any meaningful response at week 12, continued use of the drug doesn't seem to help. And so partial improvement can justify continued use, but if there's no improvement by week 12, it's probably time to move on. And I think this is important because a lot of patients and providers kind of get stuck on adalimumab, even if it's not helping, and I think we have to be ready to move on to other therapies when indicated. So for those with insufficient response to adalimumab at month 3, or perhaps some later time point, what is the best next step? Well, for most patients, this is going to be infliximab, and in particular, I mean high-dose infliximab, based off of 2 studies. The first study started patients on 7.5 to 10 milligrams per kilogram every 4 weeks as their maintenance dose. as opposed to, you say, 5 milligrams per kilogram every 8 weeks for psoriasis that you might be familiar with. And 70% of those patients starting at 7.5 every 4 met the high score metric at week 12. Patients who were initial non-responders were escalated to 10 milligrams per kilogram every 4 weeks, and half of those patients then responded at week 12. The second study looked at basically achievement of stable dosing, which was their definition of response to therapy, and 2/3 of patients ultimately got there, but it needed to be doses of 10 milligrams per kilogram every 6 to 8 weeks. And so we can conclude from these small studies that high-dose infliximab, that is 7.5 to 10 milligrams per kilogram every 4 to 6 weeks, appears to be the optimal starting dose, not just destination dose, but starting dose for patients with HS. If you're starting lower than this, you're probably going to need to escalate, and you're probably just wasting time, unfortunately. So I never start any lower than 7.5 every 6 weeks as my maintenance dose. All right, so there have not been comparative studies between these two drugs. Anecdotally, I would say infliximab tends to be more efficacious for patients with severe HS. And so just as I called adalimumab our gateway, kind of gold standard biologic for HS, I'll call infliximab our most effective biologic in common use for severe hidradenitis. Notice the dosing. We use higher doses for this disease of these medicines than for any other disease that we use these medicines for, right? So this is a very inflammatory disease state, and so the doses of adalimumab are higher even than for Crohn's disease. Some authors report intensification of the dose even to 80 milligrams weekly, and the same for infliximab. I've tried to make the case for starting at a high dose, and it's not uncommon even then to have to go up to our general maximum of 10 milligrams per kilogram every 4 weeks. You want to think about that in a patient who is doing well initially, but perhaps they're flaring at week 5 before their week 6 infusion. And then that's a patient I'm going to change the frequency or the dose to get better efficacy. So there are several issues that I think are worth discussing regarding biologics in HS. We don't have time to cover all of these, unfortunately, this morning. Things like biosimilars, combination therapy, adding spironolactone or doxycycline on top of a biologic to kind of get closer to goal, when to back off or stop therapy. But there are two I do want to highlight, the first being anti-drug antibody formation. So what is this? Well, it's when a patient develops antibodies to the antibody that we're giving them, right? And so this leads to neutralization, loss of efficacy. And we want to consider this in the patient who was responding, but now seems no longer to be getting any response from, say, infliximab infusions. And we can say from the GI and rheumatology literature that anti-drug antibody formation is at least somewhat common, here 25%, 14% in this study. It's more likely to occur when treatment is interrupted. And co-administration of immunosuppressants like methotrexate and azathioprine can lower that risk. So how should we strategize our approach to anti-drug antibodies in HS? Well, first and foremost, attend to adherence issues and dosing frequency to minimize the risk of this happening in the first place, another reason to dose higher and more often. Suspect antibody formation when a biologic therapy, which was working previously, suddenly seems to stop working. Test for antibodies, and usually this is infliximab. Admittedly, I don't test for adalimumab antibodies because, hey, 50% of the time they're not getting 50% improvement anyway. And so usually it's infliximab that I'm testing. And you can test for anti-infliximab antibodies, and that will give you both a drug level, which we don't really know how to interpret for this disease, and an antibody titer. And if there are antibodies present, I will then add low-dose methotrexate, 7.5 or 10 milligrams a week, to counter antibody formation. And in my experience, this has worked in many cases to, quote, rescue TNF inhibitor therapy. And so let's go back to our case. This patient had waning efficacy after initial response. We tested him for antibodies, and they were positive. And so I added 7.5 milligrams a week of methotrexate, improvement resumed, and here he is just after I snipped off that residual scar tissue, and he actually has had a complete remission. He's actually now years off of therapy. That doesn't always happen, but certainly a good outcome even after developing antibodies. This is a similar patient, young mother with painful erosive HS, started on infliximab, later added 10 milligrams a week of methotrexate due to antibody formation. She also had ultimately a complete remission. So to summarize, for adalimumab and infliximab, I would say adalimumab is our gold standard gateway biologic, but admittedly, response varies. About 50% of patients get at least 50% improvement. Infliximab is our most effective biologic in common use for HS, but it needs to be high dose, high frequency. Antibody formation is fairly common, and you should expect to need to troubleshoot by adjusting the dose, testing for antibodies, and so on. look, GI, rheumatology, they don't usually do this. They don't usually go to that effort of testing for antibodies because they have a lot of other drugs to choose from. In psoriasis, we have a lot of other drugs to choose from. In HS, we don't yet. And so that's why I go to these extra efforts to try to salvage effect of what I consider to be our most effective drugs. Ultimately, the majority of our biologic-eligible patients can be managed successfully with these strategies. But what's the next step for a patient with severe HS who does not respond to one of these two, or perhaps doesn't tolerate them? So at this stage, I tell my patients two things. First, we're not out of ideas. If we were, I would tell you that. There are a number of reasonable things we can try. Otherwise stated, there is hope, and that's very important. But secondly, this is going to be a trial and error process. I cannot guarantee success with any one therapy, so we have to be prepared to make adjustments. And this is a graphic from a recent study just showing some sense of the degree of switching back and forth that ends up happening in real life with biologics for HS. So how do we approach this? This is very difficult for a patient with severe disease to buy into the fact that you're going to put them on something that might not work and then maybe put them on something else that might not work and so forth. So I explain to them what this is about and how we're going to be systematic. We're going to give the drug, say, 3 months at optimal dosing, and we're going to reassess where we're at. And if we don't think we're on the right track, we're prepared to move on. And as long as they understand that there's a process and a method behind the madness, I think most patients can go along with you on that. So I'm not going to talk about all these drugs because there isn't time, but there are clinical trials now in all of these different pathways, which is amazing, okay? We can go hopefully from one FDA-approved drug for this disease to more than one FDA-approved drug for this disease. I will just highlight a few that I would say are in active use for HS in the clinic now: ustekinumab, anakinra, secukinumab, but also to a lesser degree, brodalumab, golimumab, JAK inhibitors. And all of these are reasonable therapies, but as I mentioned, be prepared for a trial and error approach. What about safety? Well, there is a track record for many of these drugs in other diseases. And again, that risk-benefit analysis, when you think about the daily quality of life impact of severe HS, that risk-benefit analysis generally comes out in favor of aggressive therapy, but questions remain. And honestly, even thinking about something like a JAK inhibitor, where there's a increased risk of major adverse cardiac events, and we know our patients with severe HS have increased cardiovascular risk, we don't know yet how that'll play out. I'm just going to highlight a couple of drugs that I think are worth you having kind of in the back of your head for patients who don't respond to adalimumab or infliximab or perhaps have an intolerance. Golimumab, Simponi Aria, is the particular formulation I'm talking about that's weight-based and IV. Has been shown to be effective in a small series of patients who had failed the prior two TNF inhibitors. But notice the dosing. This is actually higher than the label in terms of frequency. So we get that theme again. Same thing for ustekinumab. I would say the studies that have been reported have shown maybe about 50% of patients meeting the high score, but you see those dosing things, not just every 12 weeks, not just every 8, but even every 6 or every 4, and there may be better response to that more frequent dosing. Anakinra, higher response rate, 78% meeting high score, but this is a daily injection. It's not something every patient will be willing to do. And then lastly, IL-17 drugs, and I'll talk about them sort of as a group, but you can see, about 60% of patients getting that 50% improvement. But then look below here, 46% of patients on bimekizumab having high score 75, or 32% having high score 90. And then for brodalumab, these are 2 small studies, but 80% of patients got high score 75, 50% high score 100. And so this obviously needs to be borne out in larger studies, which are ongoing. But there's a sense that maybe there's a subset of patients who will have not just a good response, but a really good response to these therapies. Maybe in the future we'll be able to tell which patients those are, and we can target our therapies better. But this is certainly exciting. How are you going to get these things approved? It sometimes is a struggle, but I'll direct you to the HS Foundation website. They actually have on their website prior authorization templates for all of these drugs and more to help you get them approved for patients with severe HS. And then the last thing I'll talk about is care coordination. We have to pay attention to other disease states. Maybe the patient has IBD also. We also have to think about surgery. How do we coordinate biologic use with surgery, pregnancy? As the skin experts, we're often in the position of educating our colleagues. So how are we going to coordinate biologics with surgery? I think you probably have been there once or twice where you have a patient who's doing well, and then they get taken off their medicine to have some surgery, and then you can never kind of recapture where they were before. In the RA literature, holding infliximab versus not holding it makes no difference in post-op infection rate. And finally, there was a randomized controlled trial for HS patients for continuing adalimumab versus holding it for HS-related procedures, and showed that patients who continued the drug did better. And so we can make the argument rather forcefully now with our surgery colleagues that we should continue these drugs through elective surgery. It does not increase infection risk and results in better disease control. And then lastly, obstetrics, maternal fetal medicine. Remember that the majority of our patients, so the single most common demographic of HS patients is women of childbearing potential. And so in my experience, patients on biologics, OBGYN is comfortable continuing it. They understand that disease control of this systemic inflammatory condition is more important for mom and baby than avoiding sort of medication issues. It's really the third trimester where the antibody can cross the placenta and maybe the baby will be born with immune compromise that's of greatest concern. But even then, they're usually comfortable. Certolizumab does not cross the placenta, so could be considered. But at the end of the day, many pregnant patients with HS are not seeing a dermatologist, or if we are seeing them, we're not coordinating care with OB. We need to do a better job of this. All right, so to summarize our advanced HS management pearls, adalimumab and infliximab are the most effective and readily available medical therapies for moderate and severe HS, but appropriate dosing is critical. We have to think about troubleshooting, antibody formation, and other strategies for sustained success. Other biologics appear to be beneficial, also at higher doses, but more data obviously are needed. There's no good evidence biologic therapies increase post-op infection rate or impede wound healing, and those who pause therapy for surgery tend to do worse. So we want to advocate for our patients and educate our colleagues on that point. And despite the challenges, we should be able to make almost any patient better, at least better than they are now. And there's hope even if the process sometimes feels like trial and error. And I sincerely hope that in the future, this will be like psoriasis, where we'll be talking about HiSCR 75 and HiSCR 100 routinely with some of the newer therapies coming down the pike. So I'll stop there. I know I went a little bit over, but I thank you for your attention.
Thanks so much, Tony. It's really a pleasure to be here. You may not know, but I'm a Clevelander. Went to Heights High before I moved elsewhere, and I've lived in Chicago for most of my adult life. So let's talk a little bit about where we are with atopic dermatitis. I'm showing you my disclosures here. I've gotten very involved because it's an exciting time for atopic dermatitis. So we know that this is not just a disease of children, although that is primarily what I see in my practice, that in fact the latest studies would suggest that about 7% of adults have atopic dermatitis, although we know that most present before 1 year of age, and certainly 85% by 5 years of age. This is the curve, and as you can see, many of those who are younger actually have clearance of their disease, or at least marked improvement, by the time they are 3, 4, 5 years of age, but others serially can have the onset for the first time. And I think it's very interesting, even the group of adults who have the onset of their disease when they're older than 60. And yet it seems to be classic atopic dermatitis. So a lot to learn about why that occurs. When we're talking about children, we're talking about 2/3 of them having mild disease, but 1/3 having moderate to severe atopic dermatitis. Well, we all know the way that we treat, and it's a stepwise approach. Everybody, of course, gets their moisturizers, good skin care, trigger avoidance. We know that for the majority of patients, those who have mild disease, it's pretty easy to manage. We can use topical steroids because we don't have to use them very often, but we can substitute for those who are concerned or for sensitive areas with the non-steroidals with increasing numbers of alternatives. And then we have, of course, those that have moderate or severe disease. And I would say those are the ones who really don't have the intermittent as much as there's always something going on and you're having to treat more chronically. And that's where the art of treating atopic dermatitis comes in, of course, because you have to figure out ways to treat that are safe and yet will adequately keep someone in control. Now, topical steroids do remain the mainstay of therapy, but the nonsteroidal topicals are increasingly available, and we've just hit the 20th anniversary in the last few years of the availability of the topical calcineurin inhibitors. So the question is, can we finally get rid of that boxed warning for the TCIs? We all know that when patients go to the pharmacy, the pharmacists are required, when there's a boxed warning, to bring it to the attention of families. And we don't want them to be thinking about cancer. I don't want my child to get cancer, or the adult to say the same thing. So we have to say something. And it seems ridiculous. And indeed it is, because multiple studies now with more than 20 years of history with these drugs have shown that there really is not any evidence of an increased risk of what we worried about originally, which was the possibility of a drug-related lymphoma. Certainly haven't seen that, or even an increase in non-melanoma skin cancers. So there is no risk either of the non-melanoma skin cancer, and these long-term studies have shown no increase at all in malignancies. And in fact, just in the past year, Canada has been able to reverse its boxed warning for topical tacrolimus and then panicrolimus, since this was a class effect, but we're still stuck with it in the United States. These are very hard to reverse, but I hope it happens. Of course, we have crisaborole now, the phosphodiesterase 4 inhibitor that's approved for 3 months of age and up, and it can work very well. But in my experience, it's had more burning and stinging than I thought, based on what would be a relatively low rate in studies. So that's been the only limiting factor here. The latest is topical ruxolitinib cream, which is mild to moderate for 12 years of age and above. I wish it were available for younger children. It's not so easy to get yet, but I'm hoping over time it will be. As you know, it's expensive, but for those patients, at least in Illinois, who have insurance, we can get it with a coupon that brings it down to $10 to $20, which is great. And the studies have been very promising with the topical ruxolitinib, including in adolescents, about 20% of those who've been tested, and in adults. And as you know, these were 8-week trials, which treated this because, of course, I don't have to remind you that the JAK-STAT inhibition works downstream of a variety of different receptors and covers all the receptors that we know to be involved in atopic dermatitis, including the interleukin-31 receptor. And of course, interleukin-31 is what we call the itch-specific cytokine. So it gets both the IL-4 receptor, IL-13 receptor signaling, and the IL-31 receptor. These are just showing you again the studies that were associated with this, the phase 3 studies. And as you can see, whether we're looking at the investigator global assessment, reaching clear or almost clear with at least a 2-point reduction, whether we're looking at the eczema area and severity index reduction by at least 75, whether we're looking at the itch score from 0 to 10 and looking for at least a 4-point reduction, or whether we're looking for what's called the PROMIS 8B response, and that has to do with sleep. We can see that there's a big difference with this topical product with all of these versus placebo. Not a huge difference with the 0.75 and the 1.5%, but enough that the 1.5% was approved. I think one thing that's great about it is that there's actually been shown to be less burning and stinging with the topical ruxolitinib than the vehicle. But the one thing I would point out is that the studies have suggested that if you use it to more than 20% of the body's surface area, you're going to start getting some absorption. So the studies were done between 8 and 20% body surface area. And in fact, the product label says for use under 20% body surface area. So I just want to remind you of that, particularly when you're talking about children, that its safety is really in the less than 20% body surface area. Well, what's coming down the pike? We have roflumilast, which is a potent phosphodiesterase 4 inhibitor that's been shown to be better than vehicle in studies, and it's in phase 3 trials now, but I expect it's going to be coming out in the not too distant future. And it also has less burning and stinging than crisaborole, even though it's more potent. Not sure of the mechanism of that, but I'll take it if that's true. We have the first of the TAMAs, the therapeutic aryl hydrocarbon modulating agent. called tapinarof. This is an agonist of the aryl hydrocarbon receptor, and the aryl hydrocarbon receptor sits on the surface of the keratinocytes and modulates the barrier, inflammation, microbes, but also itch. And I'm showing you in this cartoon here that it affects artemin. And artemin is an activator of the TRPV1 and the TRPA1 receptors in the dorsal root ganglia that extend into skin. So by regulating artemin, you can also directly reduce the itch. And these studies also looked quite good with no burning or stinging, but a low percentage of folliculitis in patients. Now, we know how to handle folliculitis, but just something to be aware of when this comes on the market. Finally, I'm also excited about the topical antimicrobials. This is really based on a lot of the work by Rich Gallo and others who have shown that there's a reduction in commensals at the same time as seeing the increase in Staph aureus with flares of atopic dermatitis. And not just that, but the commensals that are there have a reduced ability to kill staph. I don't need to tell you how Staph aureus is very involved in flares and activating atopic dermatitis, in addition, of course, to causing infection in our patients. So the concept would be, could we replace with a commensal that has strong anti-staph killing activity? And that's the direction that this has gone in. So there's one that is a formulation with Staph hominis that's been extensively tested and looks to be great at killing Staph aureus and having a variety of other factors that make it anti-inflammatory as well. And the preliminary data in adults looks quite promising, so we'll see where that goes. So now we're back to our stepwise approach. And we have a lot of topicals, but we know that we have many patients who, unfortunately, at least with the topicals we've tried so far, including some chronic use of fairly potent topical steroids, we still can't get them under control. And that's when we go to our steps of moderate and often even severe. And so when we're talking about these patients who have to chronically use topicals to stay under control, we might be able to get away with the proactive therapy approach. I know this is something that I use whenever I can with those patients who just chronically have moderate atopic dermatitis that localizes to certain areas. Maybe it's the antecubital, the popliteal, the neck, certain areas that I can treat on a regular basis rather than treating the entire body. So I'll start off with twice a day with a fairly potent. I'll often use a class 2. I'll dial down after 2 weeks to a once a day once I see that they're in good shape. And then after another week or two, I will dial down to 2 or 3 times a week with that same class 3 or class 2 topical corticosteroid. Or I might even be able to use a non-steroidal anti-inflammatory based on studies like tacrolimus. And I'll keep them there, regularly using this. And that's the proactive approach that we can do when there are certain localized areas that when we stop the topical steroid, just come back again, so that we keep things on a more even keel, continuing to treat when clear or almost clear. And that's been shown to be highly effective for many patients, and also to reduce the overall use of the topical corticosteroid, and certainly reduce the risk of atrophy and other potential local effects. Of course, we can bring in some of the other newer medicines I mentioned, but if all of this approach either gives you a situation where you can only get in decent control when you're daily or twice daily putting on potent steroids, or certainly in the situations where even that's not enough, we have to move to thinking about systemic types of approaches. So when is it time for systemic therapy? Well, as we all know, with insurance now and fairly expensive medications, we need to be able to quantify disease severity and to put that right into our charts. So I'm just going to mention 2 quick tools that I've been using in my office that are pretty easy for me and everyone else to do and have been shown to be quite reliable. So for the objective assessment, that is, what do we see in front of us? We don't have time for an easy score or a score ad, but what we do have time for is a quick investigator global assessment and a quick assessment of the body surface area. One of the problems with the investigator global assessment is that it does not take into account how extensive the disease is. It's really about the intensity of the measures that you see at the areas that are affected. So this is a study that actually shows that you can take the multiplier, the IGA times the BSA, and come up with a number that very closely approximates what you'd see with an easy score, and actually very close to SCORAD as well. These were originally done with psoriasis, moved into the eczema realm, and now have been done using data from the dupilumab studies on a pooled data analysis with 36,000 data points, including more than 5,000 in children. And not only do we have a static measurement being fine, but also the EASY 50, EASY 75, EASY 90 to assess change over time have also been shown to very closely. And we're talking about a 0.95 type of correlate between the product of the IGA times BSA and the EASY score. And there are ranges that actually will tell you mild, moderate to severe. So less than 30, mild, 30.1 to 130, moderate, and then anything over 130 is severe. Now, patient-reported outcomes, as we know, are also extremely important. This is my current favorite. It's called the AD Control Tool. I put a place online where you can just download it if you want to incorporate it into your practice. It's so easy because you just ask the patient while they're sitting there or the parent to rate this on a 5-point Likert scale. And as you can see, it kind of very quickly covers all of the symptoms, the days of intense itch, how bothered, how many nights with trouble falling asleep, effects on daily activities, and effects on mood or emotion. And it's also available in Spanish, a bunch of other languages, so it's great for anybody. I also want to point out this algorithm, which was developed a few years back by the International Eczema Council. And I think it's really something that we kind of intuitively follow, but it's good to have it in writing, stressing the importance of making sure that there's been a good regimen with topical therapy, that there's been adequate education, that it can be followed and understood why the regimen, and then to ask the question, if the patient still has disease, have you missed something? Is there an alternative diagnosis? And that can be, are you managing infections well? Have you considered whether there might be a contribution to the poor sleep because of allergic disorders? Is there even urticaria, not necessarily atopic dermatitis, pulling in our allergy colleagues? And then very importantly, what about contact allergy? Has that been ruled out? And as you know, individuals who have atopic dermatitis have an increased risk of contact allergy. Showing you this picture that Sharon Jacob gave me years ago, which I really like, which was a mom was trying to clean the face and keep allergens off of it by using baby wipes that had MCIMI in it. And this kid just kept having, despite all therapy, terrible rashes on the face and elsewhere. And as you can see, it was just because of contact dermatitis. So we got to keep that in mind. So what about systemic immunosuppressants? Well, phototherapy with narrowband UVB in particular is certainly something that's been around for a long time, and it can work. You'd be surprised how little evidence there is out there, but it still can work, and it's something we do need to keep on our armamentarium. I think the problem is the difficulty in getting into the doctor's offices 2 to 3 times weekly. It's often untenable for people who work or for adolescents who are busy in school. And it's often not tolerated, of course, early on when the skin is quite inflamed. So we often might consider this for more of a maintenance type of an approach. Home units can be very helpful. I've used that quite a bit, but they're costly. They require training. It's not for everybody. Systemic steroids, big X through this. There was an article also put out by the International Eczema Council really detailing when should you use systemic steroids? And the answer is really only for specific situations in adults and almost never for children because we can't use them chronically. The people we often use them in are the ones that we're going to be treating chronically because they have severe disease, and we know there's rebound when discontinued. Yes, there are certain situations where you can use it for a brief period of time because there's a transition or there's some special event, but on the whole, we try to stay away from them, and we're having increasingly the luxury of being able to do that with new agents. Cyclosporin A, treatment of choice for those of us in pediatric dermatology for years and years, but of course you know the toxicity. And then, of course, methotrexate, mycophenolate mofetil, azathioprine, all of them with a slower mechanism of action, but perhaps safer than the cyclosporin. So we're often treating with cyclosporin A for a few months, getting patients under control, and then trying to transition most commonly to methotrexate with a period of overlap. Now, the new therapies are not just big bombs of immunosuppressants. They are pathogenesis-based. And I'm not going to spend time going over pathogenesis because you know it well, but the pathogenesis really is based on an interplay of the type 2 immunity that gets activated, the barrier abnormalities, and then, of course, the continued environmental triggers, whether that be scratch, whether that be microbes, whether that be a variety of allergens and irritants. And we know that in addition to the Th2 pathway, of course, downstream, as mentioned, we have those JAK-STAT pathways that we have to go through, for which inhibitors have been developed. So what are the new and emerging systemic therapies? Well, you all know about dupilumab. Hopefully you've already got experience with this, the IL-4 receptor inhibitor. And the exciting news is that the trials looked fantastic, as I'll show you, in young children as young as 6 months of age with good safety and efficacy. And in the next week, this is going to the FDA for review. So hopefully we'll have some good news about whether that's available for some of the younger children who are really suffering. The IL-13 inhibitors, tralokinumab's now FDA approved for adults, but the trials have been done as well in adolescents, and I expect in the next year that we'll see that available. Lebrikizumab, the trials for those who are 12 years or older are completed, and it's now in younger children trials. The IL-31 receptor inhibitor called nemolizumab. We talked about IL-31 being the itch-specific cytokine. This triggers that and has a dramatic effect on itch. And when coupled with topical corticosteroids, has done quite a good job for atopic dermatitis. It's still in trials for those who are 12 years and above. It's not yet on the market. And I'm not sure exactly where its place will be in atopic dermatitis, but certainly patients, for example, with prurigo nodularis have very rapid relief with this and other itch disorders. And then, of course, we have our oral small molecule inhibitors, abrocitinib, which is now approved for adults, upadacitinib, approved for 12 years of age and up. So we have some exciting new oral options. Just quickly reviewing, I don't have to tell you that whether we're talking about monotherapy, long-term chrono study, or those who are just cyclosporin resistant or intolerant, that dupilumab did very well in adults versus placebo. Long-term studies looked very good as well and continue to do so. In the pediatric realm, of course, we had monotherapy studies for those who are adolescents, and that coupled with topical corticosteroids only in severely affected children who were 6 to 11 years of age, as opposed to the monotherapy for moderate to severe in the adolescent group. And as you can see in all of these diagrams, whether we're looking at the Investigator Global Assessment Clear or Almost Clear or the EASI-75, big difference versus the placebo, regardless of the dosage that was used. And in these trials, the 300 milligram every 4 weeks after a 600 milligram loading dose was compared with a loading dose of twice the continuing dose, and then a weight-based dosing every 2 weeks. As you can see, 100 versus 200 in the younger children and 200 versus 300 in the older children. Now, you all know what came out of that, and we have now dose regimens that can be weight-based, based on the lower age, and only weight-based based on dosing for 60 kilos and above or less in the adolescents. And I think this, I just want to show you why we have an every 4-week dosing here in the United States for those under 30 kilos, but kept with the 200 milligram every 2 weeks for those 30 kilograms and above. I will just mention first that no red flags, same risk of injection site reactions and conjunctivitis as in adults. So these are the breakdown based on weight. And as you can see, there was a bit of an edge with those under 30 kilograms of the purple line that shows the every 4 week, and did not see that. In fact, a little bit less with those who were 30 kilograms or above. So that's why it came out to be that. That was seen in the global assessment and the EASI-75. and also in a few of the other scores. And that correlated with actually what was seen in the blood levels, with higher blood levels seen at every 4 weeks for the younger children and every 2 weeks for the children based on weight, 30 kilograms or above. Now, I will tell you that that is not the approval in Europe. In the EU, everybody gets the every 4-week dosing who are under 60 kilograms. And there is an option, if they're not doing well, to go to every 2 weeks. And I think you saw how close some of these results were, especially in the every 2-week group of the 30 kilograms or above. So I mention this just because it's okay, assuming you can get the access to it, to go every 4 weeks with the higher dose instead of every 2 weeks with the lower dose. And it's something to think about if you've got a needle-phobic patient or you're having trouble with the family. Sometimes that helps. Just quickly showing you the preschool, 6 months to 6 years, with moderate to severe atopic dermatitis. That was extended for this study. And as you can see, whether we're talking about IgA, EASI, or the peak itch responses, very strong and paralleling what we've seen in adults, and just the injection site reactions really actually a little bit lower in those who were treated with the dupilumab here. Of course, the kids can't talk in this age, many of them, but nevertheless, I think it's great that this was not a problem here in these studies. And then conjunctivitis, of course, is occurring, and we know that that's related. I want to point out with all of these studies that overall, the skin infections and even overall infections are fewer with the use of the dupilumab, not surprising, given that it helps with the skin. So the likely dosing when this comes out, which fingers crossed will be this month, is going to be 300 milligrams every 4 weeks for those who are 15 to less than 30 kilos, and for those who are at least 5 kilos, the lower limit. I don't know why you would start anybody on a systemic who was smaller than that. It's 200 every 4 weeks, so no new formulations will be coming out. A few things I just want to go through. What's new for dupilumab? No need for laboratory monitoring. The increase in eosinophils has not yet ever been clinically meaningful, but I certainly have had some kids with very high eosinophil levels, and I have to reassure, and they've been fine. Even 16 weeks out, they can still be quite high. They often go up around 8 weeks of age. So in case someone else is getting these labs and comes to you with great concern about the increase in eosinophils, I have not had any problems so far with that. I do want to mention that the dupilumab-associated facial erythema, it's certainly a real thing. Those of you who've used it, I'm sure, have seen this. And it's a variety of factors that may be at play here. They may just need a higher dose. They may have issues with a contact dermatitis that's unmasked. It may be a malassezia reactivity on the head and neck that's intensified. Demodex has also been mentioned, a variety of possible causes, but this is a study that came out of Children's Hospital Philadelphia with 12% of the patients having this develop with a mean of 7 months into the course. And required actually to discontinue. Conjunctivitis, nobody discontinued, and it was actually a little bit less than this. So didn't come out because of what was probably monitored in studies, but it's a real phenomenon, something to be aware of. And then 6 patients recently reported with the development of new onset psoriasis during dupilumab therapy. Of course, we've seen this in adults, now been described in children. And again, it takes months before one uncovers this, possibly because of shifts in the immune system when we're suppressing the Th2 cells. A few practical considerations: never start abruptly, transition from one medicine to the next with an overlap. So if I have somebody on cyclosporin, even if they say, I'm really not doing well, I will go for a month at least of overlap. I'll often go full strength for a month and then half strength for the next month and then stop it, because we got to give these drugs, when we make these transitions, time to work. We always need to think about live vaccinations when we're getting into this younger age group. It's going to be something to consider. So if possible, if within a time course, we can we can get them the live vaccination before giving it, that's fine. There was just a team in Canada that put together consensus guidelines for this and said individual basis, if somebody's doing really well, there really isn't a theoretical risk of problems with handling live vaccines. We just don't know. It's never been tested. We know that with all of these, the vaccination responses can occur, but we don't know about live vaccines. So something to think about before you start any of these biologics. The adolescents often stop. Adults often stop the topical steroids. So I've always had room, if somebody has a flare, which can occur, to go ahead and treat with that. Parents always want to know, how long do we have to do this? Whether it's an adult, whether it's a child. The bottom line is, you're giving people back their lives, you're changing quality of life with this. I don't like to stop too soon. So I'll go at least a year, and I tell them up front, could be 2. And then let's see what we want to do. And certainly when we decide to stop it, it's based on a taper, not an abrupt stop. But even with those who abruptly stopped because their insurance has changed, many of these patients have a sustained response for a while before they flare. But do space out if you're going to try to review it. I talked about the lab. What about kids in pain? Well, this could be a lecture in itself, but I always like to give the first shot in the office, teaching the parents, teaching distraction techniques, sometimes pre-treating with topical anesthetic, maybe more for show, but nevertheless it calms people. I love the pen form, which is not available right now for less than 12 years of age. But when it becomes available over the next few years, think about it for the younger kids, because you don't see the needle. It's a lot faster. Parents love the idea, like our EpiPen, and they're much more comfortable with it. And then making sure, of course, that the dupilumab's out of the refrigerator for a few hours before giving it makes a huge difference too. It decreases the thickness, the viscousness, and makes it easier to administer and seems to be less painful. And then, of course, there are a variety of techniques like Buzzy Bee and a shot blocker that can be used that are tactile stimulation, and that's particularly good for those who are 4 years of age and above. Contraindication, not conjunctivitis at baseline. Of course, I'd go ahead and get that treated, but remember that patients can actually get better with their conjunctivitis while on dupilumab as well. We know that this involves seemingly decreased moisturization in the eye. The IL-4 receptor, IL-13 receptor inhibition also reduces goblet cell mucin. And so we like to start people on ideally preservative-free eye drops as a preventive if we can, have an ophthalmologist lined up, and also consider topical tacrolimus. Almost always there's eyelid involvement. If they can tolerate using that around the eyes, it gets into the eye too, and maybe will help to reduce that. A few other quick points here. Tralokinumab's now approved for adults. As I mentioned, you could see the data that's available. It doesn't look to be quite as effective over the 16-week period of time, but then continues to go up after that. I think it's really a viable alternative, at least to try, if patients aren't doing well on dupilumab. And we'll have to learn more, but there may be less conjunctivitis with it as well, so perhaps for those patients. And this is now, I think, moving forward towards adolescence. And then finally, the JAK inhibitors. You remember that's all downstream. And this is upadacitinib, and you can see in blue the 30 milligrams, in green the 15 milligrams, and the 15 milligrams did almost as well as the 30 milligrams across the ages of adolescents and adults. There I was showing you clear, almost clear, and easy 75. Here's worst itch, as well as scores for anxiety and depression, all looking very good. And so 15 milligrams is what's been approved, 30 milligrams only if not responding to 15 milligrams. And then, of course, the treatment emergent adverse events in the 16-week period of time. Biggest thing with upadacitinib is acne, but of course we do have to worry about headache, CPK elevation, herpes infections, and counts going down at least transiently. The teen study I'm showing you here for abrocitinib, now approved for adults, but soon will be for the teens, and you can see also great results with that, whether we're talking about itch, whether we're talking about the physical signs with sustained responses. And what about the safety here? Again, nausea is really the big one. They can get acne, but it's really not anywhere near the increase that we see with upadacitinib that didn't have the nausea associated with it. Here, the gastrointestinal, nausea, vomiting even, headache again, the various laboratory tests, the same kinds of things otherwise that we see with upadacitinib. So we've got to keep them in mind. Good comparison, I'm going to go quickly now because I'm running out of time here, but good comparison in head-to-head trials of abrocitinib versus dupilumab and upadacitinib versus dupilumab. In both cases, dupilumab being about the same dose response, about the same response as the lower dose, which is now approved, the 15 milligrams of upadacitinib, the 100 milligrams of the abrocitinib. So we've got some choices. Just a few quick comments about JAK inhibitors. Great to have something that also covers itch, that can be taken orally and is rapidly cleared, can be easily stopped and started. So those patients you might have thought about steroids before, if you can get the JAK inhibitor, might be the way to go. Seasonal, intermittent for flares, and of course there are advantages for those who concomitantly have alopecia areata and vitiligo. But the big red flag is the safety. And for kids, it's typically a deciding factor, and certainly for some adults as well. So it is not first-line therapy per the label indication. And that basically means biologics, which right now is largely dupilumab first. Black box warning is on it. You're going to have to talk about it. You're going to have to get labs. But do know that the boxed warning is really not because of any studies for these JAK1 selective inhibitors for atopic dermatitis. It all relates to tofacitinib, rheumatoid arthritis, older individuals, chronic disease. And so I think that it is still a big question mark. Will nausea, vomiting, headache, acne even be limiting? Will any lab abnormalities prove limiting? We're going to be checking these, but I don't know that we're going to see any problems. But right now, it has been no signal for malignancy, thromboembolism, high-risk infections in various trials, but we'll see in larger numbers if any signal comes up. So in conclusion, a multifaceted treatment of pediatric and adult atopic dermatitis is required, but it's our new understanding of AD pathogenesis that has led to these targeted approaches, and we have a lot more coming down the pike. So thank you so much for your attention.
So this morning he asked me to talk about medical management of non-melanoma skin cancer, and since I'm a Mohs surgeon, we do a lot of surgery for these tumors, but there are instances where we need to call on our oncology colleagues and our radiation oncology colleagues to manage these patients. My disclosures are as listed here. I'm an investigator for these companies and an author for Up to Date, specifically on imaging aggressive basal and squamous cell carcinomas. So the objectives of my talk today are to discuss considerations for medical management of advanced non-melanoma skin cancer, to discuss tumor staging, discuss options for adjuvant and neoadjuvant therapy for both squamous cell carcinoma and basal cell carcinoma, and to underscore the importance of multidisciplinary management. So we'll start with basal cell carcinoma. As you know, this is the most common type of skin cancer worldwide. We see over 2 million cases in the U.S. annually. There's a small proportion of BCCs that progress to advanced stage basal cell carcinoma. Metastatic BCC is relatively rare. It's under 1%. These tend to arise in basal cell carcinomas that are large, untreated, aggressive, or recurrent, and size does matter. For example, a 3-centimeter tumor has a less than 2% risk, but a 25-centimeter tumor has a 95% risk of Mets. The most frequent sites of Mets are the regional nodes, followed by the lung, bone, skin, and liver. The mean overall survival rate is only 8 months, up to almost 4 years at the best end. Locally advanced BCC is less well-defined. Disease-driven factors help categorize these tumors. So large tumors, if they're in a crucial cosmetic or functionally crucial location, high number of tumors, aggressive histology, recurrent tumors, and obviously we also look at patient-driven factors that put patients at risk for particularly aggressive behavior, and again, underscoring the importance of multidisciplinary management. So you're very familiar with the treatment options for basal cell carcinoma. Many times it's a simple excision or Mohs surgery. We also do destructive therapies, radiation therapy for the more aggressive tumors, and I'll walk through how we think through the algorithms of these treatments. Hedgehog pathway inhibitors are some of our newest agents. The newest agent is a PD-1 inhibitor, cemiplimab, which is now FDA approved for hedgehog-resistant basal cell carcinomas. We also use chemotherapy, usually a platinum-based drug with paclitaxel, and there are a number of investigational products out now as well. So looking at BCC treatment strategy, we will stratify risk as low risk, intermediate risk, and high risk with multidisciplinary management, and this is the area I'll be focusing on today. Again, we usually start with surgery, but if surgery is not possible, we then look to radiotherapy, chemotherapy, and targeted therapies. So looking at tumors that are locally advanced or metastatic that are non-amenable to local regional therapy, we categorize it either as a locally advanced tumor, in which case we can use vismodegib or sunitinib, the hedgehog inhibitors. If these do not work, then we look at checkpoint inhibitor therapy, the PD-1, specifically cemiplimab. And if they progress on cemiplimab, we look at the platinum drugs and itraconazole. For metastatic disease, only vismodegib is approved. And again, if patients are not good candidates for that medication or they progress on therapy, then we'll go to the PD-1 inhibitors and again onto chemotherapy if need be. The hedgehog signaling pathway is important to understand. Up to 90% of sporadic basal cell carcinomas have a mutation in this pathway, and about up to 20% have activating mutations of smoothened and less commonly patch 2 or SUFU. Vismodegib was approved by the FDA in 2012 for the treatment of both locally advanced and metastatic basal cell carcinomas that are not amenable to surgery or radiotherapy. The dose is 150 milligrams daily. Sunitinib was subsequently approved in July of 2015 for treatment of only locally advanced basal cell carcinoma. And again, it's an orally administered medication. And the difference between the two mainly is you do CK monitoring both before and on therapy for sunitinib. The side effects can be quite problematic. The most common are muscle spasms, alopecia, and dysgeusia. These are generally manageable with changing how you dose the medication, but about up to 25% of patients will stop these medications because of these side effects. So it's important to counsel the patient on them and follow them very closely so that you can keep them on the medication if it's working well for them. Things we can do to help with these side effects: for muscle cramps, L-carnitine has helped, amlodipine, exercise, magnesium, massage. I have patients who swear that pickle juice helps their muscle cramps, as well as a teaspoon of mustard a day. For alopecia, you can obviously counsel them on wearing a wig. The hair does generally grow back once the therapy is stopped. They can also go on minoxidil. And for their change in taste and weight loss, we will send them for a nutrition consult and also recommend zinc supplementation, which helps some with their taste. So looking at a quantitative meta-analysis, looking at safety and efficacy for both Vismo and sunitinib. For locally advanced basal cell carcinomas, looking at 16 studies, the overall response rate was comparable for both of them. The complete response rate was slightly superior for vismodegib. For metastatic basal cell carcinoma, the overall response rate was superior for vismodegib, and the side effects were comparable for both, with upper GI distress being a little bit more common with sunitinib. It's important to know these hedgehog inhibitors can cause severe birth defects and embryo-fetal death. So pregnancy tests are done within 7 days of starting a hedgehog inhibitor. Females should use 2 forms of contraception during treatment and avoid pregnancy for 24 months after completion, 20 months after sunitinib. Males should use barrier contraception even after a vasectomy while on Vismo treatment, and for 3 months after and 8 months after sunitinib. No breastfeeding during therapy is allowed, and for 24 months following completion, and this is contraindicated in children and adolescents under 18 years old. So there's been several articles in literature showing how we can change the dosing to help the patients with the side effects. In this study, they basically gave the patients 1 week of medication, and then they were off for 1 to 3 weeks. And they found that they got less side effects. They were happy with the medication. It was working, and it was easier to tolerate. We reported Monday through Friday dosing a couple years ago in 21 patients looking at daily versus Monday through Friday, and found that the patients tolerated the medicine better and the effectiveness was very comparable. It's also important to know that other malignancies can arise on vismodegib, both squamous cell carcinoma and melanoma, so you want to follow these patients closely. If they have a new suspicious lesion, biopsy it. Resistance can occur either at baseline or during treatment, and we know that disease recurrence has been associated with proliferation of resistant, possibly pre-existing subclones that emerged after treatment of the more sensitive cell populations. So given the lack of durable complete response with these hedgehog inhibitors, we definitely are still looking for alternative treatment strategies, specifically targeting the hedgehog pathway further downstream using combination therapy. PD-1 was mentioned in 2017, and we now have an agent that's used for this, and also combination therapy. There have been a couple reports of using hedgehog inhibitors with itraconazole as well as imiquimod with good results. This study on cemiplimab was reported in 2020 and resulted in FDA approval for locally advanced and metastatic basal cell carcinomas that have failed hedgehog inhibitors or for whom therapy is inappropriate. As you can see, the overall response rate is about 31%, complete response is 6%, but the response was sustained. So how do PD-1 inhibitors work? We know that our T cells have PD-1 receptors on them that are bound by PD-L1 or PDL receptors that are found on tumor cells. And so when you put in a PD-1 inhibitor, it blocks that latching, and therefore you reverse that T cell suppression, you enhance endogenous immunity, and you unleash a long-term anti-tumor response. It's important to also understand how we grade side effects, grade 1 being mild, up to grade 5 being death for these immunotherapies. And these are terms that our medical oncology colleagues are very familiar with, and we should become familiar with as we see our patients in our office to kind of head off the path of any severe side effects for our patients. So for example, with cemiplimab, this is a list of immune-immediate adverse effects, which can be anywhere from pneumonitis, colitis, hepatitis, endocrinopathies. The most common is hypothyroidism, nephritis. They can get Stevens-Johnson, neurologic toxicity. So again, you want to follow these patients very closely with your medical oncology colleagues. And sometimes the reaction is just enough to take down the dose or temporarily stop it and then restart it. And sometimes the reactions are so severe you need to discontinue the med altogether. Other ways we've looked at improving our response to hedgehog inhibitors are surgically debulking the tumors. We reported 3 patients in 2020, along with our colleagues at Penn, that responded particularly well after we've surgically debulked the tumor, and I'll show you an example of this in just a second. And you think if you just take down the bulk of tumor, the medicine has less tumor cells to attack, and they may need to be on it a shorter amount of time. That was my thought at the time. So there is, however, a molecular basis of improved response because there are 2 main cell populations in basal cell carcinomas. The body of the tumor expresses both sonic hedgehog and Notch signaling, but the cells in direct contact with the basement membrane have lower Notch signaling and are resistant to a hedgehog inhibitor. So if you can surgically manipulate those cells, you can potentially change the Notch signaling and make the patient more responsive to the vismodegib. So as I mentioned, we know we reduce the tumor burden by debulking the tumor, and therefore the patient may need to be on the medicine a shorter amount of time with less side effects. We know that we can alter cell signaling pathways with tissue remodeling, and that may improve the response. Debulking may reduce the overall genetic heterogeneity of the tumor cells, which again may improve the response. And interestingly, in other tumors, surgical manipulation of cancerous tissue like breast tumors and ovarian cancer has upregulated Notch signaling in those cancers. So theoretically, it could act to our advantage with basal cell carcinomas. So this is a patient I actually showed in 2018 when I gave this basal cell talk, and I wanted to give you an update on her. This is a recurrent nodular basal cell carcinoma that's got a lot of blood at the surface. That's why it looks like a melanoma. We did image her. The tumor was in the nasal bones. Fortunately, it did not go into the periorbital fat. She did not want Mohs. She didn't want a mutilating surgery. So I debulked the tumor. This is the first patient that this was done on, and this is 6 weeks later. On the vismodegib, she maintained her nose. There is tumor intranasally that I did not surgically debulk, but the vismodegib took care of. This is her 3 years after the vismodegib. She did get 1 small recurrence here at the edge, but all in all, she had a very good cosmetic and functional outcome. This is a man with a primary nodular basal cell carcinoma that crawled over the lash margin onto the mucosa. He absolutely refused surgery. We talked about vismodegib. I surgically debulked this with a curette and a scalpel, put him on the vismodegib, and this is him 10 months into therapy. I can tell you I could not surgically make it look this good. He's now 1 year into the therapy. We've stopped the vismodegib. I'm going to see him about every 3 to 4 months and monitor for any recurrence, but he's got a good functional and cosmetic outcome. And this is a man with a neglected nodular and infiltrated basal cell carcinoma here on the chest. We did image this. It's not in the sternum. It's not in the ribs. He presented to one of our cardiothoracic colleagues, and he thought cutting it out was not a good idea, which was correct. So we decided to debulk this tumor and then put him on vismodegib. So this is debulked 6 weeks after shave debulking, and this is after 1 month on the vismodegib. So we'll continue to follow him, and our hope is that we can prevent him from needing any surgery at all, or if he does need surgery, it'll be a much smaller procedure. We've also used hedgehog inhibitors in a palliative way. We reported 3 cases back in 2020 of very large exophytic basal cell carcinomas that were causing pain and bleeding. The patients did refuse surgery, and it did work quite well and help these patients as far as their symptoms. We can also use hedgehog and pathway inhibitors as an adjunct to radiation therapy with good outcome, and there are 2 patients that were reported in 2015. You can also shrink the tumors, as I showed you on a couple cases, before surgery, or obviously you can also treat them with curative intent, but we do know that you can shrink these pretty significantly so that the morbidity of the surgery would be lessened. And this is a patient I showed you guys 4 years ago, and this is an update on her. She had a 25 centimeter ulcerated basal cell carcinoma on her back, and the only reason she came to medical treatment is she, from chronic bleeding, bled down on a hemoglobin of 3.2 and fainted and ended up in the emergency room. And this is her tumor. Her husband was doing very elaborate wound care for her with Duoderm, and this is after 1 month on the vismodegib. This is after 6 months on the vismodegib. We continued it for 3 more months, and then that area was resected by neurosurgery and plastic surgery. I read the tissue was 78 pieces. The tumor was clear everywhere except a small island right over the spinous processes, which is what we saw on her MRI. The spinous processes were shaved. She got post-op radiation and a repair, and she's now 6 years post-op with no recurrence. So this is where we are now. So an example of multimodality treatment. And lastly, this is a 63-year-old music teacher, had venous stasis ulcer on her right medial ankle, had lots of surgeries to fix it, but this ulcer kept enlarging. A biopsy was done showing an infiltrated basal cell carcinoma, which on MRI was very deeply infiltrative into the foot musculature, so surgery would be very morbidity laden. And this is this tumor here. So her venous stasis ulcer started here, but the suspicion of basal cell carcinoma came because it started crawling across the top of her foot. This is in 2014. This is after 1 month on Vismo. This is after 4 months on Vismo. She was taking it daily and stopped it because she was driving and her hands got stuck on the steering wheel and she couldn't get them off. And she was so frightened by that, she called me and said, I have to stop this medication. So I couldn't talk her into less dosing. She stopped it, and this is a year later with just that 4 months of treatment. I biopsied here and I biopsied at the edge, and there was no residual tumor. This is the alopecia she experienced, which can be quite disturbing, especially for our female patients. So this is 1 year after Vismo. This is 3 years after Vismo, and I contacted her. She now lives in Colorado. This is she sent me a picture last week. This is 7 years after vismodegib with no recurrence. So this was a complete response. And lastly, just keep in mind this hedgehog pathway, because it'll give you ideas on other ways to attack these basal cell carcinomas. Coming up, there is a topical sirolimus study for our basal cell nevus syndrome patients, which again targets the hedgehog pathway at a different point than our vismodegib and sunitigib. So on to squamous cell carcinoma. This is a really helpful article. I advise you to take a look at it. As you know, there's no standardized management approach for patients with cutaneous squamous cell carcinoma who develop metastatic or locally advanced disease or who are not candidates for curative surgery or curative radiation. So they got this leadership panel together and used a Delphi consensus methodology to put together guidelines based on literature on how to manage patients. And they presented their information with 12 questions, and I'm going to follow some of those to present this information. So this is, as you know, the second most common skin cancer. There's about 700,000 cases in the U.S. There's over 8,000 deaths per year for an overall mortality rate of about 3%. New cases have increased over 200% over the past 30 years, likely due to a growing elderly population and increased screening. Fortunately, most patients have localized low-risk disease that can be treated with surgical resection. There is an average risk of nodal mets of up to 6%. We use 2 staging systems currently, the AJCC8, which mainly uses size of tumor and the presence of bony erosion or bony invasion or perineural invasion. The Brigham and Women's staging system looks at high-risk factors, specifically tumor diameter greater than 2 centimeters, invasion beyond subcutaneous fat, poor differentiation, and perineural invasion. And you count the number of risk factors, and that tells you if the patient is a T1, T2A, or T2B, 3 or 4, again, based on the number of risk factors. We also look to the NCCN guidelines for skin cancer management, and they categorize tumors a little differently: low risk, high risk, and very high risk. Any tumor over 4 centimeters is very high risk, regardless of location. Also, poor differentiation puts it into very high risk, as well as desmoplasia, deep invasion, and then prominent perineal invasion of tumor of nerves over 0.1 millimeters. So it just kind of gets you in the mindset of how aggressive you need to be based on these factors. So looking at high-risk basal cell carcinomas and management, if a patient comes to you and you categorize them based on either Brigham and Women's or the NCCN guidelines, you first want to ask yourself the question, are they a surgical candidate? If they are, can you get clear margins? If you don't get clear margins, you can give them adjuvant radiation therapy, or go back and do more surgery. Our goal is to surgically clear this if we can, but sometimes we can't. If they're not a candidate for surgery, we look to the PD-1 inhibitors or definitive radiation therapy, chemotherapy, or cetuximab, and I'll walk through each of these in just a minute. So what indicates a diagnosis of locally advanced over metastatic squamous cell carcinoma? Your locally advanced tumors are going to be patients who have such large tumors in sites where surgery or radiation are not great options due to morbidity or unacceptability to the patient. In-transit mets in the dermis or fat between the primary tumor and the first echelon lymphatic node basins are also locally advanced. Metastatic squamous cell carcinoma obviously connotes that the tumor has spread to a distant organ or is in the subcutaneous tissue beyond a draining lymph node of the primary SCC location. We know that patients with advanced squamous cell carcinoma have very poor prognosis with high recurrence rates, specifically 50% with large caliber nerve invasion, high metastatic rates, up to almost 33% with poorly differentiated tumors, high mortality rates, even with the addition of adjuvant radiation and chemotherapy. And it's important to know and acknowledge that these patients often have a poor quality of life from the disfiguring surgeries that many of them go through and the psychosocial impact of the disease. So we're trying to really address the entire patient when we choose our treatment modalities. So how do you determine non-candidacy for surgery in patients with advanced disease? We have a tumor board, as do a lot of institutions, and we look at the patient's clinical photos, we look at their imaging studies, and we make a decision and we weigh the benefits and risks of surgery versus radiation versus a PD-1 agent. And again, you need to talk to the patient thoroughly about what would be involved in the surgery and what their chance of cure is and what their other options are. So it truly is a team approach. How should staging systems be used to manage these advanced tumors? So we use staging systems to help identify patients who are at risk for local recurrence, metastasis, or death, and they may be useful to compare outcomes in some clinical trials, and there's a lot in the literature about comparing Brigham and Women's and AJCC, and we actually think the Brigham and Women's is slightly better at stratifying risk currently, but we're looking at revising that with them. The Brigham and Women's tumor staging system, again, doesn't take nodal or distant mets into account. We use it to estimate the risk of recurrence or mets and identify patients who might benefit from radiologic nodal staging or increased surveillance for recurrence. Your AJCC 8 and 2 identifies a patient who is at increased risk of regional failure after surgery with or without radiation, who may benefit from systemic therapy after lymph node failure or if the nodal disease is inoperable. And obviously, mets to distant organs will identify patients in need of systemic therapy. So this is from Chris Schmaltz's et al.'s article in JAD in 2018, specifically advising for patients with high-stage Brigham and Women tumors, T2-3, T2B and T3, and then your AJCC8, T4, which is bone invasion. If they don't have palpable nodes, you still need to look. So either do a CT. If it's positive, you do a lymph node biopsy. If it's negative, consider a sentinel lymph node or ultrasound monitoring of those nodes. So, and you want to continue to monitor those high-risk patients either with ultrasound or CT, and obviously with your physical exam going forward. So we've combined our squamous cell carcinoma database with Brigham and Women's, and we've come up with some really helpful information, specifically in regards to in-transit metastasis from cutaneous squamous cell carcinoma. We started with 18 patients with in-transit mets, compared them to 247 high-risk squamous cell carcinoma patients, and looked at overall survival and disease progression. And what we found was that the patients with these in-transit mets had outcomes similar to locally advanced non-metastatic, meaning nodal disease, carcinoma patients. So our advice after this article was that larger studies are needed. So we did a larger study. So we did a larger study looking at 518 patients. node negative, node positive, also metastatic patients. And what we found looking at the 72 patients with in-transit METs is that they had clinical outcomes that were similar to the patients who were node positive, with an increased risk of recurrence and worse survival than the T3 and T4 AJCC8 patients, so patients with bony invasion. That's really important to understand. So our advice after looking at this larger group was that the presence of satellitosis should be incorporated into clinical staging systems, which currently it is not. It is for Merkel cell and melanoma, but not for squamous cell carcinoma. And these patients should be considered for anti-PD-1 studies as well as neoadjuvant immunotherapy studies. We also, with our Brigham and Women colleagues, looked at lymphovascular invasion and recently reported the largest study looking at LVI. And of our 10,000 squamous cell carcinoma patients, 78 had LVI. The low-stage cutaneous squamous cell carcinoma patients with LVI had a significantly higher 5-year cumulative incidence of local recurrence, metastasis, and disease-specific death. The higher stage tumors had a higher 5-year cumulative incidence of METs and disease-specific death, but no difference in local recurrence. So again, our advice or our conclusion at the end of this analysis was that future staging systems should consider incorporating LVI. So should synoptic path reports be used with squamous cell carcinoma? My vote would be yes. Right now, there are no formal guidelines for synoptic pathology reporting to assist in tumor staging and clinical decision-making. Things that we'd like to see on a report: the size of the tumor, which we also have in our notes, but they also measure at the time of path, the thickness or Breslow level of invasion, the differentiation, which again we know is subjective, desmoplasia, perineural invasion of nerves over 0.1 millimeters, is there LVI, invasion of fascia, muscle, or bone, what is the extent of lymphocyte infiltration, are there in-transit METs? And again, we need to give our pathology colleagues good specimens to be able to look at these features and give us a good synoptic report, which is only going to help us manage our patients. So a little superficial shave biopsy may not give them the information they need and may not tell us how aggressive that tumor is. What patient or tumor characteristics suggest increased risk of recurrence or metastatic disease? We know obviously that immunosuppression plays a role. So our organ transplant patients, our CLL patients, HIV patients, patients who are on iatrogenic immunosuppression, tumor location in high-risk sites, the temple, ear, vermilion lip, periorbital skin, anogenital skin, patients with albinism, XP, recessive EB, dystrophic EB, involvement of a high proportion of evaluated lymph nodes or extracapsular extension out of the node. It's also important to know, looking at the literature, that currently we know that sentinel lymph node biopsy may detect occult METs, but the impact on therapeutic outcomes has not yet been established. So we do need controlled trials to look at this. So sentinel lymph node biopsy right now is just not automatically recommended in these high-risk patients. This is a helpful chart, maybe hard to see from the back, but from Chris Schmaltz's article in Derm Surgery, again, looking at location, sites that I mentioned, size over 2 centimeters, and the corresponding risk of recurrence and rate of METs. And you can see these are very high compared to a tumor in a low-risk site that's small, that's well differentiated. So again, you're taking into account all these factors to try to gauge the risk of your tumor. So as far as supplemental tests, right now there are reports out looking at genetic alterations, protein expressions, looking at specific cellular infiltrates, and tumor-specific characteristics that may be associated with poor outcomes, but this is evolving information. Probably the most promising area is our gene expression profiling, which I'll go through a couple slides on in just a second. And we're just looking at another tool that will help us better risk stratify our patients so that we can tailor-make the treatment as well as the follow-up, so that we want secret sauce, basically, to tell us how to best manage those patients, because on a lot of these studies, they found very low-stage tumors had a very high score and high risk of metastasis, and very high-stage AJCC or Brigham and Women's tumors had a very low risk, a class 1 risk. So we really want to match up the patient's risk with their management and follow-up. This was the Sentinel paper published in 2021 that reported development of a 40 GEP, gene expression profiling test, that stratified high-risk squamous cell carcinoma into class 1, which is low risk, class 2A, which is high risk, and class 2B, which is highest risk. So it's basically over 50% for your class 2B. Or close to 50%. So for the validation cohort in this paper, the 3-year metastasis-free survival rates were 91%, 80%, and 44%. So 1, 2, and 3. And again, this positive predictive value of 60% was achieved for the highest risk group, the class 2B, which is an improvement over the current staging systems. The negative predictive value, the sensitivity and specificity were comparable to the current staging system. So again, it's just another tool. This is the most recent publication on GEP out of the same group that looked at 420 patients. And again, more of these validation studies are needed. What we're doing is looking at known patient outcomes and going back to the original tumor of those patients who had horrible outcomes, and then look at the gene expression profiling to see what markers on that tumor are telling it to behave badly for metastasis. What's the role of radiation therapy in advanced squamous cell carcinoma? Definitive radiation or systemic therapy may be considered in patients for whom surgery is not an option. And again, this is decided in our multidisciplinary team tumor board discussions. You need to make sure you're adequately imaging those patients before the treatment as well as at certain points through the treatment to monitor the response in addition to your physical exam. Adjuvant radiation therapy called ART may be considered with positive or uncertain surgical margins if a patient has multifocal or large caliber nerve invasion over 0.1 millimeters. Patients at high risk for regional or distant METs based on the features I mentioned before. Large or multiple squamous cell carcinomas or some with intracranial extension, recurrent locally aggressive squames, and tumors with lymph node involvement. What is the role of systemic therapy, specifically immunotherapy? There are 2 PD-1 inhibitors that are now FDA approved for patients with locally advanced or metastatic squamous cell carcinoma who are not candidates for surgery or radiation. Appropriate use in immunosuppressed patients has not been established because they were excluded from the original trials, so they are currently approved only in immunocompetent patients. Any treatment decisions with your transplant patients, and this is mainly your renal transplant patients, looking at immunotherapy, risk of death with surgery, and radiation should involve a discussion of organ rejection, which in these patients can be up to 50%. This was the original article on cemiplimab showing a 50% best overall response rate. This is a very impressive clinical picture, and they had an over 60% durable disease control, so very impressive initial report. The degree of PD-1 expression on tumor cells is not associated with the degree of response, so that's not something we routinely check on these patients when we're making a decision to do PD-1 therapy. These are medications given IV, generally every 3 weeks. And again, it's important to know that right now there are a lot of studies looking at neoadjuvant as well as adjuvant use with radiation and or surgery. The currently published studies show that with cemiplimab and pembrolizumab, your overall response rate's anywhere from 42 to 50%. Your complete remission is anywhere from 5 to 17%. This is a patient of Dr. Koifman's who had a recurrent squamous cell carcinoma. She's in her late 80s. It had been operated on twice in 2016. They then did radiation and cetuximab. It recurred again. So then she was placed on pembrolizumab and had a complete response. This is the MRI showing the tumor in the orbit and a parotid involvement here. And this is complete response on physical exam as well as on her imaging. Patient from our tumor board last week had a recurrent squamous cell carcinoma of the periorbital skin, very hard to resect this, and is currently responding extremely well after 6 cycles of cemiplimab. And then another patient from our tumor board with a very large scalp squamous cell carcinoma, poorly differentiated with a good response to date to the cemiplimab. Looking at chemotherapy or other targeted therapies, these can be considered in patients who are not candidates for immunotherapy or who have progressed on immunotherapy or cannot tolerate the side effects. It's in the adjuvant setting, we use it with chemoradiation. Most commonly used meds are cisplatin and cetuximab, which is an EGFR inhibitor. The cisplatin may have a superior overall response rate compared to cetuximab, but with more side effects and a poorer quality of life. The EGFR inhibitors may be more suitable for maintaining a quality of life than the platinum-based chemotherapy. And just showing the studies to date summarized here with cisplatin, interferon, oral 5-FU, radiotherapy, and carboplatin, we have as high as 100% overall response rate and with a 53% remission with radiotherapy and carboplatin and dropping anywhere in the 14 to 60% range with the other medications. And the EGFR studies, cetuximab is most commonly used, but other agents are listed here. The best response to date has been with gefitinib with a 45% overall response rate. How should patients be assessed for failure to treatment? We're obviously following them as a multidisciplinary team very closely in the first 2 years, and then if they're NED, at that point we back off. We do radiologic surveillance as well, more closely in the first 2 years, and beware of potential for pseudoprogression of the tumor and expected toxicities that may occur with immunotherapy. When should we use immunotherapy with surgery and radiation. This is currently under study. There is no definite guidelines for this. There are two randomized controlled studies now with cemiplimab and pembrolizumab in patients who are having surgery and radiation. So they'll be randomized to placebo or one of those two agents. And follow-up recommendations, we see these patients pretty closely every 3 to 6 months. We instruct them on monthly self-skin and node exams, obviously counsel them on sun avoidance and sun protection. Oral retinoids and nicotinamide are considered to reduce risk of squamous cell carcinoma. You obviously want to adequately treat their AKs so they don't progress onto a squamous cell carcinoma. And for our organ transplant patients, you consider reducing immunosuppression and switching to an mTOR inhibitor if possible. Acitretin was shown in renal transplant patients to decrease the number of squamous cell carcinomas with an effect seen within 1 to 2 months. Indications over 5 invasive squames in 2 to 3 years, significant field disease, high-risk tumors, and metastatic tumors. We generally start patients 10 milligrams every other day and increase up to 20 to 30 milligrams a day as tolerated. You're obviously monitoring the lipid profile and LFTs, and it's important to remember this is teratogenic, so the female patients are advised on contraception for 3 years after completing therapy. Nicotinamide is a form of vitamin B3, which in 2015 was reported to lower the risk of new squamous cell carcinomas by 30% and basal cell carcinomas by 20%. The dose is 500 milligrams twice daily. No lab monitoring is needed, and it's safe in pregnancy. And lastly, oral captocytidine. This is an off-label use. It's a prodrug of 5-FU. It's FDA approved for colon, breast, and rectal cancer. It does reduce squamous cell carcinomas in organ transplant patients, as well as decreased AK and BCC incidence. Indications, multiple invasive squamous cell carcinomas despite optimization of risk factors, trials and other chemopreventative agents. Dosing is 500 milligrams every other week for 1 to 3 months, and then you increase to 1,000 milligrams twice a day, 2 weeks on, 1 week off. You want to make sure you check your DPD levels before treatment, and you're monitoring CBC and CMP monthly during treatment. So in summary, for advanced squamous cell carcinoma, this kills as many patients in the U.S. yearly as melanoma, so it's important to be aware of this very small but important high-risk population. We generally start with surgery mainly for these patients or excision with a complete margin check. Our T2B and T3 Brigham and women patients have up to a 20% risk of nodal mets, and they need very close nodal staging and surveillance. And the only FDA-approved infusion therapy now for anti-PD-1 therapies with cemiplimab and pembrolizumab, with a response rate up to 50%, disease stabilization up 70%, and complete response about 20%. And important to remember, your transplant patients have up to a 50% chance of organ rejection. These are the investigational studies that are currently ongoing for squamous cell carcinoma, because obviously we haven't hit the holy grail as far as our effectiveness and sustained response, so we'll stay posted on these, and I thank you for your attention.
Thank you for the introduction, Tony, and thank you for having me. Today I'll be talking about what happens behind the curtain that you try to interpret in your reports. So we'll talk about updates in the diagnosis of cutaneous malignancies. For the purposes of this talk, that's just going to be melanocytic tumors, but honestly, the non-melanoma skin cancers are easy to diagnose, so we don't want to waste any time on those. And then we'll discuss updates in the treatment of some of the cutaneous malignancies as it applies to pathology. So, a lot of the melanoma diagnoses that we make are simple, and I would say that in older patients with sun-damaged skin, having architectural atypia alone can warrant the diagnosis of melanoma, for example, lentigo maligna. But if you have cytologic atypia, it's even easier. If you've got severe cytologic and architectural pleomorphism in any patient, the diagnosis is easier. But there really is a spectrum. So on the left, you've got your compound nevus. You want it to be small and symmetric and circumscribed. Histologically, you want the cells to be nested, located at the tips of the ridges. You want cells to mature as they descend into the dermis. You don't want to see dermal mitoses. And all the nevoid cells are the similar size to basilar keratinocytes without pleomorphism. Now, your most, obvious melanoma will be larger than 6 millimeters, asymmetric, poorly circumscribed. It'll be, have single cells along the dermal epidermal junction or up into the stratum corneum with pagetoid spread, bridging of nests, impaired maturation, dermal mitoses, et cetera. And some examples might look like this. So on the left, you have just a nice ordinary compound nevus, and then on the right, superficial spreading melanoma with lots of pagetoid spread into the epidermis and pleomorphic cells. But there's 50 shades of gray in melanocytic diagnoses, and this is adapted from the WHO classification of skin tumors. And really, they split melanocytic neoplasms into pathways, which incorporate the amount of sun that's exposed to that area and how it's thought to be implicated in the mechanism and pathogenesis. Each sort of pathway has a benign starter lesion. You can see here common nevus, Spitz nevus, acral nevus, blue nevus, et cetera. And then they have like intermediate low-grade melanocytomas and intermediate to high-grade melanocytomas. So in your most common nevus, this would be mild and severe melanocytic dysplasia. And then a malignant pathway. So, what you're most familiar with is superficial spreading or nodular melanoma, or here desmoplastic melanoma, or lentigo maligna melanoma. But there's other entities in between, and we call these melanocytomas, such as BAP inactivating nevi, deep penetrating nevi, pigmented epithelial melanocytomas, Spitz tumors, which really are kind of borderline genetically and so histologically can be difficult. And then, of course, excluding a melanoma that arises in one of these tumors can be quite difficult. But as you see here, many of these tumors are defined by certain genetic pathways, which will come into play later as we think about diagnostic aids. So I would say in our daily practice of cases that we receive from all of you, as well as consultation cases from other pathologists really around the country, the most difficult lesions are those with spitzoid atypia in patients who are young or middle-aged. If they're older and sun damage, it's much easier, as we talked about. And things that we look at again are asymmetry, lack of circumscription, deep dermal mitoses, and often we use immunohistochemistry in these cases. So the stains that you probably are used to hearing of that are pretty much applicable to most melanocytic lesions are P16. In a nevus, P16 should be retained in all of the cells. And in melanoma, it can be lost either in one regional area if you have different clonal populations in the tumor, or diffusely. P16, if you'll remember, is the protein that is produced by the CDKN2A gene, which is implicated in familial melanoma syndrome, and is the second most common mutated gene, I would say, in melanoma. HMB45 is a marker of immature melanosomes. We want it to be lost with dermal descent. It can either be diffusely retained or completely negative in melanoma. And we want our cells to have a low proliferative index, Ki67, in the dermis. And this can be increased in melanoma, although usually not that high, usually around 3 to 5%, or you can see them deep in deep melanocytes. And if any of the above are not reassuring, we often go to molecular testing. So this was a case on a 14-year-old patient, a thigh lesion. You can see it's quite large. The cells are spindled and epithelioid, arranged in intersecting fascicles. And there were lots of dermal mitoses in this case, including deep dermal mitoses. And if you look at the chromatin, which is often a reflection of just DNA, gains and losses in DNA, aneuploidy, it's amazing how our eyes can actually see this just by studying the chromatin pattern. You see that there's, prominent nucleoli and some hyperchromasia and coarsely clumped chromatin. So HMB45 was diffuse in this case, so that's worrisome. We want it to be basically expressed here at the top and gone in the deeper cells. P16 showed some areas of loss here in the center part of the lesion. Ki67 was quite high, even including deeper cells. And so we ended up fishing this case, and it was, and that's fluorescence in situ hybridization, and it was negative. So we ended up calling this an atypical Spitz tumor. But that's just an example of kind of a case that we would do immunohistochemical staining. So I want to briefly talk about PRAME. That's the new IHC marker on the block. It stands for Preferentially Expressed Antigen of Melanoma. It was discovered in 1996 as the gene coding for the antigen that was being recognized by tumor-infiltrating lymphocytes in a metastatic melanoma deposit in a patient. The DNA for PRAME has been found in several tumor lines of various origins, so it's not necessarily specific for melanoma. But 91% of melanomas express it. And it's also found in the testes and at low levels in the endometrium, ovary, brain, etc., but at much lower levels. And it's a proposed novel cancer testes antigen, just like MAGE, BAGE, GAGE, etc. And it's thought that promoter demethylation controls the upregulation in cancer. So it was first written about really as an independent biomarker for metastasis in uveal melanoma. So this just shows that the class 1 cases that were PRAME negative had a much higher progression-free survival than the ones that were PRAME positive. And this compared to disomy 3 and actually increased the predictive value of disomy 3 when used in conjunction to predict survival. But here they were using PRAME PCR, and the IHC actually was quite difficult to interpret and was not used as a prognostic marker. This is another publication that came about a year later. This is, and you might be familiar with this as dermatologists. I'm not aware of it being used too much in our clinics, but it was published by a group at Northwestern looking at a 2-gene molecular assay for cutaneous melanoma. You can see they adhere this tape onto the lesion, and then they do PCR. And PRAME was one of the genes, and they claim it to be 91% sensitive and 69% specific for melanoma. And then this is really the first paper looking at the IHC. So an antibody was developed at Memorial Sloan Kettering, and basically PRAME was tested in 100 metastatic melanomas, had an 87% positivity rate, and in 155 primary melanomas with an 83.2% positivity rate. Most of the nevi were negative, 86.4% were negative, 13.6% were positive. It was usually focal, and one of those was a Spitz nevus. So I just want to summarize. I could do a whole talk on PRAME, but I think that the data is still, like most of the other tests that we're used to dealing with, a little bit less impressive in borderline melanocytic tumors and melanocytomas. And our internally obtained data in Spitz tumors is somewhat conflicting with the literature, and it may not be great in that instance. So then we sort of move on to molecular diagnostic tests. So traditional ones include comparative genomic hybridization and fluorescence in situ hybridization. And then relatively new is a MyPath melanoma, which is a gene expression-based assay, and up and coming, I would say, is next generation sequencing. So array CGH, as you probably know, you label patient tumor DNA with control DNA, and you hybridize them to a platform, and then you use immunofluorescence detector to demonstrate gains and losses in segments of DNA. And the first study on this looked at CGH in melanomas here on the left, and you can see lots of copy number gains and losses that were really seen in almost all melanomas and not seen in nevi. And you can see this is one in chromosome 11, which turns out to be HRAS, and these turned out to be atypical Spitz tumors. But, you know, CGH has a lot of difficulties. It's a long, cumbersome test. It requires a lot of tissue. It's expensive. Not all labs can do it. So what they did is take like the most common gains and losses noticed with CGH and put them into a FISH assay. And so we've had FISH at Cleveland Clinic for a long time. It looks at gains and losses with a certain threshold. And again, it's based on CGH recurrent aberrations. There's a 90% concordance with CGH in the literature. And again, FISH is more simple. You can look at smaller tumor cell clones. For example, in a melanoma arising in a nevus, there's only a 30-cell requirement. So based on multiple publications, the overall sensitivity and specificity is around 87 and 95% in fish to detect melanoma. But this is much less in ambiguous cases, just like PRAME. So 43 to 100% reported and 33 to 83% specificity reported in ambiguous cases. And so that's really why we added 9p21. So again, that's looking for homozygous deletion of CDKN2A, which is the P16 gene, in nuclei and MYC amplification. And that improves sensitivity in Spitz lesions to 70%. So this is an example of a paper published in Fish, looking at fish in the diagnosis of nevoid melanoma. So as you probably know, nevoid melanoma mimics the nevus both clinically and histologically, but they identified clues to nevoid melanoma, one of them being the so-called puffy shirt sign. So you can see that the expansile nests here in the dermis are causing elongation and compression of the rete ridges, making them very slender. And of course, the way that we can most confidently spot nevoid melanomas with dermal mitotic figures, which are shown here. And then this paper, 74% of the nevoid melanomas were fish positive. This is a paper looking at fish in Spitz neoplasms in kids. So this was a 6-probe fish, which is what we have at the Cleveland Clinic. 85 of the cases had adequate follow-up. 20% of those 85 had a positive fish result, and the most common result was homozygous 9p21 deletion. There were 4 patients who had spread beyond the sentinel lymph node basin, which we all know that atypical Spitz tumors can spread to the sentinel lymph nodes, but typically don't do anything beyond that. And so sentinel lymph node biopsy is no longer recommended for Spitz tumors. 4 cases had spread beyond that, so that's more of a malignant phenotype. 3 of the 4 cases with disease spread beyond the sentinel lymph node biopsy had homozygous 9p21 loss. Again, P16 loss, and so those were considered, these 4 cases were considered to be Spitz melanoma. So people began equating homozygous 9p21 loss in fish with Spitz melanoma. Now that's become a little bit more controversial. I want to highlight this patient. It was a 6-year-old male with a lesion on the abdomen. His fish showed one abnormality, which was homozygous 9p21 loss, and he actually died of disease. Now, I'll highlight here that we did not know, so back then they weren't doing whole genome sequencing or even panels on these tumors, so we don't know if he actually had a BRAF mutation and should have been classified as just a conventional melanoma. And so the next kind of assay that's come down the pipe in looking at differentiating these lesions is MyPath melanoma, as I alluded to. So before we asked Dr. Fontaine about the DecisionDx, so the gene expression profile for predicting prognosis, this is a diagnostic aid. So it looks at mRNA from 23 genes in 3 different categories. One is the cellular differentiation category, which ends up being the PRAME gene, and then 8 immune signaling genes in the second category, and then S100 protein-related genes in the third. And it has an algorithm which weights the expression of these to give a melanoma diagnostic score. And it's really developed to differentiate primary melanoma from nevi. And so the scores look like this. On the negative side, those lesions are benign. On the positive side, those would be malignant. And then there's this little small overlap, and you get a report consistent with benign or malignant. The reported sensitivity and specificity, excluding this indeterminate zone, was 94% and 90%. And this is kind of what the reports look like, although I think they've changed recently with the acquisition by Castle from Myriad. So we did a study with University of Michigan and MD Anderson looking at fish compared to the MyPath assay. So there were 117 biopsies, 39 were straightforward, including 24 benign and 15 melanomas. And then the majority of the cases were challenging, and they were considered to be challenging by this expert group of dermatopathologists. And I don't want to go through all of the tables too much in detail, but this was looking at all of our unequivocal cases, and fish slightly outperformed MyPath in these straightforward cases. They both had reduced sensitivity and specificity in challenging cases and performed roughly equally. So you can see here, like fish, sensitivity of 56%, 83% specificity, and then MyPath in the challenging cases, 52% and 80%. And the results are overlapping, but there was some disagreement. So in the agreement between them in the unequivocal cases was 80% and 70% in the challenging cases. They performed better or worse, but they agreed with each other more in Spitz lesions. And so I think we have to ask ourselves, who is right in this case? Is fish right? Is MyPath correct? Are we correct as a pathologist when we disagree with both of them? And, could we be overcalling ambiguous cases? And is that why the sensitivity is reduced in both of these assays? And I think it's hard because clinical behavior is really the gold standard. And a lot of these difficult cases come in as consultations, and we don't always get the clinical follow-up data. But we're trying to look back at this cohort in particular. But take home, when do we use which test? So when do we use any molecular tests, I'll say? So very atypical things in young patients, because you have to assume that most of the time those are benign lesions. But if there's pleomorphism and atypia that you have no other explanation for, or you just can't let rest, you do a molecular test. In borderline lesions in middle-aged patients, right? Like melanoma is a disease that can affect relatively younger patients. And so, 25 is not that young in melanoma compared to other cancers. And then, which test do you use? Well, we had been using fish when we're very worried, when there's a large dermal component, and just technically you're looking at dark field microscopy. It's hard to count those cells if there's not a good dermal component amongst other non-malignant cells, or if they're very inflamed with tumor-infiltrating lymphocytes. And then Myriad, I would say MyPath, I would say we use when we're more committed to a benign or malignant diagnosis. Lesions are mostly junctional or very inflamed. So as I alluded to before, our main diagnostic issue is with Spitz tumors, and these are challenging for even experts to classify. We know that Spitz nevi really just behave like regular nevi by and large. Atypical Spitz tumors can disseminate and spread in the sentinel lymph nodes, but don't do anything else. And then malignant tumors are thought to have additional hits, which allow for widespread dissemination. But the term atypical Spitz tumor has really been controversial. It was historically a wastebasket for when you couldn't decide what it was. Other choices would be atypical Spitz nevis, atypical spitzoid proliferation of uncertain malignant potential. And it was really subjective as far as you had a Spitz nevis, but there were other features that were worrisome for melanoma. And there's poor inter-observer agreement. I think now we're coming into an era where we have genetic molecular tools to better classify these cases. So this was really the Sentinel paper in Nature Communications, 2014, and it showed that the majority of Spitz tumors have translocations in a defined set of genes, including ROS1, ALK, NTRK1, BRAF/RET, and various partners. And so these fusions are involving receptor tyrosine kinases, and they tend to occur in younger patients. They're mutually exclusive with themselves and HRAS. They activate MAP kinase and PI3 kinase pathways. And they're also known to occur in other types of cancers, as an aside. We also know from papers like this that melanoma really genetically is not driven by tumor translocations. It's driven by BRAF in younger patients with intermittent sun exposure, and RAS and NF1 in older patients with more chronic sun exposure. And then, rarely you have these, or you have a subset which is triple wild type, and they have complex rearrangements. And then there's other genes that you see in melanoma, which are listed here, which really don't overlap that much, if at all, with atypical Spitz tumors. And so that's just seen here. You can see like TERT, TPEN, or PTEN, et cetera, BRAF driving these pathways over here, and then all these translocations listed here, HRAS, ALK, ROS, NTRK, in the SPITS pathway. So bearing that in mind, we asked whether we could use next generation sequencing to classify melanocytic neoplasms. Because the benefit of doing that was in the cases that were malignant, we would also already have predictive data for data management, such as BRAF mutational status. And so we looked at 31 melanocytic lesions. This was a pilot study. They included melanocytomas in the blue category, epithelioid nevi that we couldn't otherwise classify, 7 Spitz tumors, about half being benign and malignant, and then 15 melanomas just to establish sort of baseline findings. And we compared results with FISH in 12 of the cases. And we were able to use 170 pan-solid tumor NGS panel, which is shown here, because a lot of the genes in that panel, including translocations and amplifications, are involved in the pathogenesis of melanocytomas and melanomas. And so this is looking at a summary of the results. We see that when you go from, epithelial nevi, blue nevi variants, benign Spitz tumors, malignant Spitz tumors, and melanoma, with increasing histologic atypia, you see an increase in number of mutational variants. Known number of pathogenic mutations increased as you got more atypical and malignant, was increased in melanoma relative to the others. NF1 and NRAS mutations were not seen outside of melanoma. P53 was only seen in melanoma, and that was the only thing in our study associated with poor outcome. TERT promoter mutations are not seen in benign lesions. And then, of course, BRAF V600E and MAP2K1 variants are not seen in benign Spitz tumors. By definition, that would exclude a Spitz tumor. And so, and 3 out of 3 of our benign Spitz tumors had gene fusions, so that's great. That agrees with the literature. 1 had 2 fusions, which was a BRAF and MET fusion. So true melanocytoma, which is thought to have at least 2 genetic hits. 1 malignant Spitz tumor had a fusion, which was EML4, but it also had TERT promoter and BRAF V600E mutation. And then hardly any melanomas had gene fusions. Gene amplifications were only seen in melanoma. They were seen in 5 out of 15 of them. Spitz tumors were ultimately classified as malignant if they had BRAF and MAP2K1 pathogen. Also had a TERT promoter mutation and EML4 fusion, as mentioned before. And 2 of the 3 Spitz tumors that were ultimately classified as benign had other variants. 1 had a BRAF fusion, 1 had a CHEK2 and a FGFR2 variant plus a ROS1 fusion, and then the 1 had a BRAF fusion, MET fusion, and MSH6 variant. So that's gratifying for me because obviously, they look funny on H&E stains and you can't classify them, and this is why, right? They've got all these they have several driver mutations. And so we proposed criteria for classifying malignancy. So they're listed here: Spitz morphology with a pathogenic BRAF or MAP kinase point mutation, pathogenic NRAS or NF1 mutation, gene amplification, TERT promoter mutation, or greater than 15 total aberrant alterations. And all of the malignant cases met criteria. Oftentimes 2 or 3 criteria were applied in classifying them. Then we compared in a subset of patients, FISH and NGS. There was complete agreement with our benign variants here and our straightforward malignant variants here. But it ends up being that in benign Spitz tumors, actually 1 was called positive by FISH, and we still called it benign, and the NGS agreed with us. And then in the 3 that were both sequenced and had FISH, 1 FISH called negative, the NGS ended up calling it malignant, and we agreed with the NGS. So it looks like the NGS performed a little better than the FISH. This is that case. So this was a Spitz tumor. It we called it malignant, even though FISH was negative, because NGS showed BRAF-V600E and EML fusion and TERT promoter mutation. And you can just see that it's broad. It's got a lot of architectural disarray across the junction, tumor infiltrating lymphocytes, and lots of pagetoid spread. And I think a good example of why this would be Spitz tumor is this dusty cytoplasm in the melanocytes, which has been called pulverocytes for dust or pulverized, and that's usually indicative of a BRAF mutation. So, I think that melanoma FISH is okay, but at the end of the day, the biology is still determined by the driver mutation. These melanoma-associated mutations exclude Spitz in favor of a Spitzoid lesion, and could have been present in some of the cases that were previously reported to be fatal in children. Kinase fusions need to be present to call something a malignant Spitz. And if it is a malignant Spitz with a kinase fusion and not one of these other mutations, it seems that the outcome might be better for equally staged conventional melanomas. Here's a real-world example. So this was a pigmented lesion on the upper arm of a 43-year-old woman that we received in consultation from an outside pathologist. The outside clinician really felt that this was benign. The contributor and ourselves felt that this was an evoid melanoma. So of course we did FISH. We have it in-house, thinking, oh, it'll be positive or done. Well, the FISH was negative. So we ended up sending it to Caris for whole genome sequencing. And it showed a high tumor mutational burden, NRAS mutation, TERT promoter mutation, and lots of other pathogenic variants. So this is a case where I think NGS just is really good, and we're trying to bring it as a routine diagnostic test in-house. Here's another example of a case NGS helped with. So this was an 8-year-old boy. Case was received in consultation. I only have the IHC stain slide from the original biopsy. We signed it out as favored traumatized Spitz nevus and recommended re-excision. P16 was retained and BRAF-V600E was negative by immunohistochemistry, so we felt comfortable in that. 1 year later, there was not a re-excision done, and it recurred in the scar and with an adjacent nodule. This is the in-scar recurrence. This is the adjacent nodules you can see here in the dermis and here. And lots of cytologic pleomorphism, mitoses, lots of epithelioid pleomorphic clones, mitoses, deep mitosis tripolar, another deep tripolar mitosis. So we sent it for FISH. The FISH was positive this time. And so we were, obviously nervous about this, but we ended up sending it to UCSF for consultation and 500 gene NGS sequencing. And this was found to have a MAP3K8 gene fusion. So these, which is reported in high-grade atypical Spitz tumors. And it didn't have any other melanoma-defining mutations. So it was signed out as favor high-grade atypical Spitz tumor, and there was no TERT promoter mutation. So it was re-excised again, and patients doing well. So just a little bit, these MAP3K8 fusion and truncated lesions in pediatric patients are thought to be mediators of particularly high-grade atypical Spitz tumors. That was our own personal first encounter with these. They have striking atypia, frequent P16 inactivation. Genomics are thought to predict behavior. One child has died of disease thus far. And this is a case that was published in the literature. So just to conclude on this diagnostic part, the diagnosis and risk assessment is increasingly reliant in borderline tumors on genetic characterization, and especially in Spitz tumors in young patients. NGS will most likely replace other molecular diagnostic tests. Now this has like a 2-week turnaround time, so please bear with us. We want the right answer. I've got a case right now pending NGS on the pinky of a 19-year-old that I feel is an atypical Spitz tumor, and don't want this patient to have an amputation. So, but it takes time sometimes to get the right answer. But this will allow for increasingly accurate tumor classification, new tumor discovery, and simultaneous guidance of precision oncology-based treatments. I just want to quickly touch on update and path treatment. This has come up a little bit before in the previous talks. So Someone asked about Castle Decision DX, whether we do it here at the clinic. I'll just present briefly a couple of the largest papers. This one had 161 patients with class 1A and B and class 2A and B results. Breslow's ulceration mitosis, sentinel lymph node biopsy, and the GEP class 2B were all associated with recurrence-free and distant metastasis-free survival in univariate analysis. Breslow and ulceration were associated with RFS and multivariate analysis, and Breslow only in DMFS and multivariate analysis. So here it suggests that maybe, Breslow and all these other factors that we already report in our synaptic tumor reports are better than the GEP. Okay, this was another paper, 523 patients, class 1 versus 2. And both recurrence-free and DMFS was predicted in univariate analysis by GEP, Breslow, ulceration mitosis, sentinel lymph node biopsy. And then all of the GEP, Breslow, and sentinel lymph node biopsy was had predictive value in multivariate analysis. Importantly, 70% of stage 1 and 2 patients who ultimately developed metastasis were identified by the GEP test. And so I think what I've seen is that we use it mostly for patients with thick tumors, but a negative sentinel lymph node biopsy, which we really feel that they need closer monitoring with ultrasounds, that's typically where it gets sent. This is the Castle Decision DX test for squamous cell carcinoma that Dr. Vidimos alluded to and touched on, so I just want to kind of briefly go over it. Looked at 586 patients from 23 centers. They had at least one high-risk feature by NCCN guidelines or greater than T1 by AJCC or Brigham Women's criteria. They had a discovery and validation cohort, and you can see here 200 patients fell in class 1, 91 plus survival, 93 patients in class 2A, 80% survival, and then 2B had a 44% survival, and they were the minority of patients. All the other typical things were predictive: tumor thickness, diameter, poor differentiation, perineural, et cetera, and the stages. Again, this shows that class 1 and 2A were really widely split in survival from class 2B. And I think importantly, it has the GEP profile has the same negative predictive value as AJCC and Brigham Women's and NCCN, but it had a much better positive predictive value. So because these high-risk features cannot often be detected on initial biopsy, this test can help for surgical decision-making was basically the summary in combination with other clinical pathologic factors. PD-1, PD-L1, IHC, and melanoma. So as Dr. Fontaine alluded to, immunotherapy is first-line treatment. Melanoma, the staining to be called positive has to be greater than 1% of tumor cells, and it has to be membranous. This is associated with improved immunotherapy response overall, but mostly just when looking at monotherapy with pembrolizumab. And it's not specific and certainly not good enough to preclude treatment in anybody. There's no statistical superiority when you're looking at PD-L1 and predicting responses to Ipi-Nivo combination. And so I've noticed that, this gets ordered occasionally at CCF for patients who might not tolerate dual therapy to determine the likelihood of response to monotherapy. And then BRFE600E, as Dr. Fontaine talked about, is approved for stage 3 melanoma to prevent recurrence. So all stage 3 and 4 patients get BRAF-IHC in PATH automatically. If there's greater than 95% of tumor cell staining, we call it positive. We don't order NGS. The clinician can order it at their discretion. If it's negative, we call it negative and recommend. If it's less than, we'll call it either negative or heterogeneous tumor staining and recommend sequencing with NGS. We won't reflexively order it. We used to, but now we leave it up to the clinician because we're doing whole genome sequencing with Caris. And that's it. So thank you. Sorry I went a little over. It's great to be here.